what is the optimal radiation therapy dose, and fractionation with the use of gold nanoparticles. And I will look at this for the case of head and neck cancers. In case of head and neck cancer, the tumor control can be achieved significantly faster when gold nanoparticles are used. That is, for lower total absorbed dose. We also want to identify what the total radiotherapy dose is to achieve 100% tumor control after fractionated treatment. For example, 2 grays per fraction, when applying gold nanoparticles to fully oxygenated and hypoxic head and neck cancers. And is the total dose that leads to 100% tumor control affected by the introduction of multiple nanoparticle injections, altered by radiotherapy treatment regimens, or by alteration to tumor alpha-beta ratio values. Additionally, we will look at whether reoxygenation and accelerated repopulation, that means tumor recovery after irradiation, will affect the total dose required to kill the tumor. So in this work, we have performed Monte Carlo modeling. So this is a primary computational study. And the basis of it is a HIP-RT computational model that is capable of producing a range of biological plausible outcomes, accounting for both cellular and tumor behavior and radiation interactions. In this study, we have modeled head and neck tumor, but we have added heterogeneous gold nanoparticle uptake probability and are calculating the corresponding dose enhancement ratio, where dose enhancement ratio is the percentage of cells killed with gold nanoparticle relative to the percentage of cells killed without gold nanoparticles. So the tumor growth that we are conducting in silico has biological properties of the head and neck cancers, and we are applying the proper cellular hierarchy so that the tumor starts from the division of stem cells, where the stem cells can also become transient cells or differentiated cells. The transit cells will then become fully differentiated, and both differentiated cells and transit cells have a limited lifespan. Only the stem cells can divide indefinitely. So we have applied unique properties relating to cycling, number of possible generations of daughter cell production, natural apoptosis. We have also mimicked oxygenation level allocations based on head and neck cancers, and the tumor contains oxygenated as well as hypoxic cells. And we have grown 10 computer-generated tumors of up to 10 to 8 cells. Obviously, we have no subjects because this is a computational modeling, and we have tested a number of variables. Primarily, we are looking at the uptake of the gold nanoparticles, and the probabilistic curve for the uptake is based on the experimental measurements conducted at the University of South Australia. So this shows us what is the probability that a cell will ingest 0, 5, 10, 15, or 20 or more picograms for gold nanoparticle administrations. We have then performed 25 simulations per parameter set using 5 different random seeds and 5 different in silico tumors, both oxic and hypoxic. So this is the structure of our simulation. First, we have a tumor growth where we grow the simulated tumor, and the hypoxia or oxygenation is incorporated using partial oxygen pressure probability distribution. Then we deliver the tumor radiation, So we use X-ray irradiation, for example, 2 grays to the whole tumor, but we have also applied other fractionation regimen. Then we calculate the probability of cell death using the linear quadratic model. And then we also incorporate changes to the modeling, different dose per fraction, different alpha beta ratio, different cell cycle phase, different nanoparticle uptake, different oxygenation. And then between the irradiations, fractions, the surviving cells keep proliferating. And as the time advances, tumor and cell data are saved at set time periods. Between the treatments, between the fractions, the tumor can repair damage and reoxygenate. And we have incorporated this as accelerated repopulation and reoxygenation. A number of fractions, the treatment and regrowth, repeats until the last clonogenic cell is killed or maximum dose is reached. So the first thing we want to model and ask about is the gold nanoparticle content dynamics. How is the nanoparticle content kept by the cells? So we modeled 3 scenarios where we looked at weekly oxic tumor content dynamics after a single injection. And what we can say that the 8 days or 15 days after the injection, the gold nanoparticle will diminish quickly. And this is both due to cell division, cells dying, and biological mechanisms where the cells will eventually eject the gold nanoparticles from the body. We also look at the weekly oxic tumor content dynamics after weekly injections that we basically give as injection every single week. And you can see that even after 8 days and 15 days, we maintain the content of gold nanoparticles, but then the large availability of the larger contents is minimal. However, if we deliver 2 injections of gold nanoparticles every single week, we can then achieve higher concentration of gold nanoparticles in some cells. So it appears that administration of 2 injections every single week throughout the treatment delivers the best gold nanoparticle uptake throughout the course of treatment. So this is the type of simulations runs that we have performed. We have delivered, for example, 2 grays per fraction 5 days a week. We have modeled the same scenario with tumor repair and accelerated repopulation incorporated. We have modeled hyperfractionation with 1.2 grays per week, 6 days per week. We have modeled SABRE with 12 grays per fraction, treated 2 times per week, once daily. We have also looked at different alpha beta ratios of 3, 5, and 20. We have looked at the reoxygenation due to tumor shrinkage, and here are the results. So let's now first look at the fully oxygenated tumors for 2 scenarios, 2 grays per fraction of radiation dose and 1.2 grays per fraction. The first number is the number of stem cells for 0 gold nanoparticles. The second number is the single gold nanoparticle injection. The third number is weekly injection. And the last number, the fourth number, is twice weekly injection. On the y-axis, we have a total dose required to kill all the cells. And the dashed line is showing the clinically acceptable tolerance doses. So what we see that for 2 grays per fraction and fully oxygenated tumor with no reoxygenation and no repair, even without gold nanoparticles, we can kill the tumor at about 50 grays. However, as soon as we apply accelerated repopulation, the red dot here, that means there is a tumor repair and tumor regrowth between the fractions, we cannot clinically deliver high enough dose without damaging normal tissues to eradicate the tumor. However, if we apply a weekly injection of gold nanoparticles or twice weekly injection of gold nanoparticles, we radiosensitize the tumor sufficiently enough to eradicate all clonogenic stem cells. Similarly, we achieve good outcomes when 1.2 grays per fraction is used twice daily with and without accelerated repopulation. When it comes to SABR, stereotactic ablative radiotherapy, we can similarly see that with the use of gold nanoparticle and accelerated repopulation, complete tumor kill can be achieved. Now, you may know that 50% of head and neck cancers are actually hypoxic. So looking at the oxygenated tumors is really unrealistic and very optimistic. So let's have a look in case that we have tumor hypoxia. In case of tumor hypoxia, we can see that even the 2 gray tumor regimen cannot completely eradicate tumor. And this is becoming much more worse if accelerated repopulation is also implemented. That means the tumor regrows between the treatment fractions. And we cannot really achieve tumor eradication even with the gold nanoparticles. However, as the tumor shrinks with subsequent fractions, reoxygenation happens. So when we have radiotherapy with accelerated repopulation and with reoxygenation, because as the tumor shrinks, the hypoxic cells have access to blood vessels, we immediately see that the application of weekly or twice weekly schedule of gold nanoparticles enables us to eradicate the tumor within clinically deliverable absorbed radiation doses. We see a similar scenario for SABR. So if you have a hypoxic tumor, SABR itself cannot eradicate the tumor. But if bi-weekly gold nanoparticles injections are used, excuse me, tumor control can be achieved. If we look at the dependence of tumor eradication as a dependence of alpha-beta ratios, better results are achieved for higher alpha-beta ratios. And once again, the use of gold nanoparticles, either weekly or twice weekly, brings previously incurable tumors below the clinically deliverable radiation dose, and tumors now can be eradicated. So what are the key implications of our simulations? Single injection of gold nanoparticles has minimal impact on reducing the total dose. Significantly large reductions in total doses are associated with weekly and bi-weekly gold nanoparticle injection frequencies. An increase in tumor alpha-beta values resulted in an increase in the required total dose with and without gold nanoparticle injections. simulated 1.2 gray per fraction doses twice daily and 12 gray per fractions twice weekly radiotherapy regimens were associated with reduced total dose outcomes compared to standard 2 grays per fraction radiotherapy simulations. So in conclusion, gold nanoparticles permit the potential reduction of total delivered doses and therefore normal tissue complications. And they offer effective treatment of more radioresistant tumors, such as those that are hypoxic or rapidly regrowing that may be otherwise uncontrollable by radiotherapy. Thank you for your attention.
Okay. I thank Professor Eva Bezek for the very fine presentation on the application of potential of using gold nanoparticles for improving the cure rates and the control of the head and neck cancers. I have one small question.
Sure.
When you are saying that the accelerated fractionation schedule work better, what is the potential doubling time that you assume for the head and neck cancers?
It assumes the accelerated repopulation to kick off after 2 weeks.
Oh, yes.
And we are also assuming about 6% of clonogenic stem cells in the tumor.
What is the volume doubling time actually for these tumors?
It might sort of depend on from patient to patient, but yes, the observable effects you will start seeing in the tumor growth macroscopically after 2 weeks.
Okay, thank you so much. And the paper is now open for discussion. If there is any, I allow one question I shall allow because we have already crossed the time limit actually. So any questions from the audience? Anyway,
no, thank you for having me.
Anyway, if there are no questions, I truly appreciate this paper. I am actually clinical radiobiologist, and I really appreciate your paper and also the work that has been done showing the potential of gold nanoparticle injection to really control tumors which could otherwise be not controlled. Exactly. I know the head and some of the head and neck cancers are very refractory, and I think
absolutely.
I think this new modality will surely improve the cure rates and also the tumor control. And thank you for your very interesting lecture.
Sir, may I have a question, please? This is
yes,
Dr. Madhubala.
Yes, please.
So my question is, this silver nanoparticle, the gold nanoparticles which she is using, has some kind of toxicity study on buildup of these particles in the body has been done?
This is all the simulation, so not a clinical work. The clinical trials are only now just starting with nanoparticles, and actually they are not the gold nanoparticles. Okay. There are other types of particles. However, with gold, one of the reasons that gold is being used is that it's inert. It's not reactive, yes. So that's why the expectation is that hopefully it will have a minimal toxic effect. The gold nanoparticles are though usually encased in PEG, which is basically a plastic compound to ensure that the nanoparticles are not spotted by the lymphatic immune system in the bloodstream, to allow them to absorb in the tumors.
Okay. Thank you. Thank you.
Pleasure.
Yeah. Good morning, Professor Rao. Dr. Vijay Kalia from Nimhans, Bangalore.
Okay, Dr. Kalia, you ask.
Can I ask a small question? Is there time or you are already overshooting? It depends on you. You are the organizer of the conference also. I thought it was BS Rao I was talking.
I have.
Please, one question you may ask.
Hello.
I can ask. Uh-huh.
If your question is brief, yes, go ahead. Yes.
Yes, it will be very brief. Good morning, madam. In the third world countries, normally any new therapeutic modality which is introduced, the cost benefit ratio comes into picture.
Absolutely.
So what is the expectation that what will be the difference between this therapy and the conventional therapy as far as an average patient in a developing country would be concerned?
Yes. So to begin with, I don't think we are using radiation biology to our advantage enough, even without gold nanoparticles. There is evidence from studies in Denmark that when you take into account accelerated repopulation and hypoxic nature of head and neck tumors, and instead of 5-grade treatment regimen, you treat this cancer with hypofractionations, 1.2 grades 6 times a week, twice daily maybe, with $100 worth of hypoxic sensitizer, you can increase the 5-year survival from 50% to about 70 or 80% for minimal costs. And then the gold nanoparticles, of course, they would come at more cost, can improve severe hypoxic tumor reaction even more. But if you look at the radiobiology of the tumor and just adjusting the fractionation regimen and use hypoxic sensitizers, we can achieve significant improvements for minimal costs.
Madam, I'm not sure which hypoxic sensitizers you have in mind, but I think nonetheless, our discussion can go on in the interest of the conference time.
Yes.
It is better if we proceed ahead. And thank you, Professor Rao and Professor.
Thank you, Professor Kalia.
I will like to be able to get in touch with the speaker so that I can correspond with her later through my email.
Sure. So now we will switch on to the next speaker.
Dr. Rao, may I speak one question for one minute only?
Yes.
Prof. Very good morning. First of all, I would feel regret for the delayed response on your bills. Around thousands of students, youngsters, from the research scholars and PhD students and our MSc students, they all are online and offline. Would you like to give some message to all our students? What kind of research they can do further in the field of radiation science? Only for 1 or 2 minutes. The students, they are very excited to see your talk. I humbly request you to say a few words for our young students and researchers.
Okay, I don't know. This is putting me a bit on the spot, but I think anyone who chooses to work in health sciences, including medical physics, has a very important beneficial role. Where I, for example, look at my career, I am a researcher, as well as a clinical medical physicist, as well as I designed radiation oncology in 3 hospitals departments. And when I look at what's most important in my life, it's not the paper that got lots of citations, but it is the difference that I've made to the community where the cancer patients have directly benefited. So I was part of the team, for example, that built a radiation oncology center in Darwin, which is in North Australia. And before then, the patients had to fly for 3 hours to Adelaide to get treatment. So it is when I see the direct impact that my work has on the quality of lives of cancer patients and their families that I think is the most satisfying achievement in anyone's careers. any of your students who decided to study medical physics or radiation biology, I believe that they will have a very important role to play in the society, and it is a most fulfilling career. So despite any difficulties that the pandemic or any other situation, lack of resources may bring to them, I wish them all the very best to succeed. I wish them to develop determination and resilience, and the future is theirs.
Yeah. Thank you so much, Dr. Eva. Thank you very much for doing this.
My pleasure.
Totally agree.
Okay. Now I think we will move on to the, thank you very much, Dr.
Thank
Eva. And we will move on to the next speaker now. And it is Dr. Amit Alok from INMAS. And Amit Alok will be presenting the repurposing of the clinical drugs for radiation protection. And I request the speaker to finish the lecture in about 12 minutes so that there will be 1 or 2 minutes left for the discussion also.
Sure, sir. Sure, sir.
Okay, over to you.
Okay, sir. Thank you, sir.
Yeah.
Good morning, everybody. I am very thankful that Dr. B.S. Rao is chairing this session. He has been our one of the, he has guided us to establish a biodosimetry laboratory in INMAS. And I am very thankful to him that he is there. But today I will be presenting this. I will be presenting, from beginning. Today I will be presenting the topic of repurposing of clinical drugs for radiation, for radiation protection. So why we have chosen this thing is because repurposed drugs takes less time. Repurposing of drugs, because in radio protection and radiation countermeasure agent, we have started working, scientific community has started working right after World War II. And it has been already more than 6-7 decades of research. But other than amifostine, we do not have any really any drug, and amifostine too has some serious side effects because of which it is not being usually used. Yes. So a lot of drugs has been tested, and few has been tested on NHP. Some has been withdrawn after NHP. Then getting radiation cohorts is not possible. So repurposing, as it takes, since the safety profile is already established for these drugs. So I basically worked on 2 drugs, diclofenac sodium as well as tetracycline hydrochloride. And so I will be presenting basically these 2, the data on these 2. So as we know that this pharmacokinetics and pharmacodynamics of diclofenac and tetracycline are well established. And the probable mode of action for radioprotection is by inhibiting LOX lipoxygenase. So which I will investigated for diclofenac, and in tetracycline, it is antibiotic. It is used as antibiotic. So its action maybe because of inhibiting protein synthesis and radioprotective whatever I have worked, I will share. So as we know that de novo drug discovery takes time. We have to work on cellular models, then we go for mice, NHP, then trials are required. Then in this work, the basic idea of this work, I will just go on my work. Yeah, the basic idea of the work when I had chosen diclofenac was that there was a crystal structure of diclofenac with phospholipase in the year 2006 in the biophysics department of AIIMS. So from that, I got an idea that if it inhibits lipoxygenase, then it should inhibit. This was the hypothesis based on which I started working. That if it inhibits lipoxygenase, then in the downward pathway, it will reduce the formation of ceramide, which essentially leads to apoptosis. So probably this may be the probable mechanism of action of this. So this was the study design. I worked on cell line with ex vivo models, then with NHP, and then on human peripheral blood lymphocyte, because we have a established biodosimetry laboratory. So the knowledge, the technique there, I had applied in radiation protection. So I choose a V79 cell line because it is a this cell line is very in most of the papers. This is a sensitive cell lines which is used for radiation studies. So we have procured it from NCCS Pune and characterized and carried it as we can see that diclofenac sodium has a single peak. It is a pure molecule. So we did MTTSA to establish its first toxicity in mice. Then we found that at this much dose, 50 micromolar or 100 micromolar, it is non-toxic even up to 1 millimolar. So now,
Amit, please put it up on the PPT mode. We are not able to see your slides moving.
Okay, ma'am. Okay.
Yeah, please. You have already skipped so many. We didn't see them moving.
Sorry.
So put it on the presentation mode.
Sorry. Is it visible now?
It is visible, but it is not on presentation mode.
Okay, ma'am.
Put in the full screen.
Full screen. Niche jao. There is a command on the lower taskbar.
I'm not getting it.
Go to the lowest taskbar of your system on the right hand side.
I'm already there, ma'am.
Amit, just press the F5 button.
Is it visible? Is it visible?
Now it's okay.
Yes.
Okay.
Please go ahead.
Okay, ma'am. Sorry. We missed a lot of things, but I will not take time. I will just start my work. Right. So, yeah. So we had chosen V79 cell lines, then we did its MTTS, and then we did chronogenic survival on V79 cells. And it is chronogenic survival. Is it coming? Wait, it is coming.
Yeah, please go ahead.
Yes, go ahead.
Yes. So on chronogenic survival, we have shown this diclofenac sodium to give protection in the V79 cell lines with a dose modification factor of 1.47. Then we went to see whether it has some antioxidant potential also. Then we did DPPH, FRAP, and ABTS assay. These are antioxidant assays which are done to determine antioxidant potential. And then we came to know that it has ABTS property, a good ABTS property with IC50 values of around 34 micromolar. Then we were on PB, plasmid DNA and bovine serum albumin. These are standard models to study, check the effect of radioprotection. And we have seen its radioprotection in plasmid DNA also, that with two concentration of 100 micromolar and 250 micromolar. And it had dose modification factor of 50 and 111 at respectively at both the concentrations. Then in BSA, as a model, we check the carbonyl concentration. Carbonyl is generated because of radiation. So diclofenac sodium at different concentrations reduced the formation of carbonyl radicals. And it was hydroxyl radical scavenging assay using 2-deoxyribose, because 2-deoxyribose is for determination of free radical formations. And in this assay, that diclofenac has reduced the formation of 2-deoxyribose. It has reduced the formation of malondialdehyde formation. And this is a gel, SDS-based gel, in which it is shown that diclofenac sodium we can appreciate that diclofenac sodium at different concentrations have restored the major gel band, which is of bovine serum albumin, which is around 60 kilodalton weight. Then we went to study in mice, C57BL6 mice. C57BL6 is one of the radio resistant mice, and it is highly recommended mice for doing radiation protection studies. So we have used this mice. We did histology, alkaline comet assay, as well as gamma H2X assay. In histol, this is a blood profile of blood hematological data that on day 1 and day 4, because from day 7 mice started dying. So we do not have that data, but this is a villi number for GI data, gastrointestinal tract data. And here we can see that it is coming. Yeah, it is coming. Here we can see that diclofenac sodium has restored the this villi number, but at the same time, at higher when the days progressed, it has also some toxicity. So this is one of the gray area which we need to investigate. And it is also known that diclofenac sodium, recurrent use of diclofenac sodium causes toxicity, causes kidney toxicity and nephrotoxicity as well, liver toxicity. But it was not a chronic use; it was a single use. Then we did comet assay in mice in different organs, and in mice also diclofenac sodium has shown protection at 7.5 gray when treatment was given. So now in gamma H2X also done with diclofenac sodium, and diclofenac sodium has shown protection at both at 1 gray and 2 gray in gamma H2X. Then this is a whole body survival in which diclofenac sodium has shown protection of around say 47.5% against lethal dose of radiation. This was a published work, except this histological data we have not published, but other things we have published. Then we have checked its effect on HPBL, human peripheral blood lymphocyte, through cytogenetic methods like dicentric, micronuclei, and gamma H2X. So this is just how our dicentrics are formed. Here we have shown that diclofenac sodium at 10 micromolar, 100 micromolar, and 1 millimolar concentration at 2 gray of radiation has shown given protection. We also have shown its effect at 5 gray, but that I am showing right now. This has reduced micronuclei formation, similarly at 2 gray and 5 gray. And after administration of radiation, we added diclofenac sodium. Then also it has shown some potential. And this is data of gamma H2X, in which it is shown that diclofenac sodium at 10 micromolar, 100 micromolar, and 1 micromolar concentration has given concentration-dependent reduction in gamma H2X foci. So this thing also we have published in mutation research. So the significant it is shown in HPBL as in human peripheral blood lymphocyte using cytogenetic method. It has shown protection. These are some gray areas with diclofenac sodium where it has shown some toxicity, which we will investigate, because histological study we have to see whether does diclofenac amplify the effect of radiation damaging GI, because I think so, and we will investigate it. Then we have also done combination of tetracycline as well as diclofenac in whole body survival, and we have not found any additive effect, so we will also investigate on that. The second study was that this is the application which we will come. Second study with tetracycline hydrochloride also followed similar, almost the same similar study. As we can see, it is a pure molecule having absorption maxima at 2 peaks. Then its ABTS assay was done, and tetracycline hydrochloride, so this excellent ABTS activity, having TEAC at 2.4. Then DPPH assay was done, and with DPPH assay, its IC50 was around 72.5 molar at 60 minutes concentration. Then this is a plasmid PBR 322 model, in which also tetracycline has shown its protective effect. Then in ex vivo, we have determined its efficacy in reducing mitochondrial membrane potential in liver using rhodamine, as well as tetracycline reduced T-bars formation in brain tissue isolated from mice by reducing the formation of thiobarbituric acid reactive substance.
Can you complete in 1 minute, please?
Done, sir. I will definitely do it. Then with BSA as a model, it has shown its reduction. So this was it has shown reduction in of malondial formation, as well as in whole body survival. Tetracycline gave protection of around 20-25%. There was earlier one paper which had shown that tetracycline gives protection of around 80-85%, but we did not get this. So anyhow, we communicated it, and our paper was also accepted. But this is our when earlier somebody had shown its protection as 85%, but we did not get it. We get only roughly around 20%. So this is a summary. So the take-home summary is that we can see that diclofenac and tetracycline both have different properties, but yet they have shown protection potential. So what I propose, and I also talked in my department, that we should create a database of such clinical drugs for radiation countermeasure property, because as we can see that during time of emergency, radiation victims are normally, they do not require single drug. They are normally put on multiple drug regimen. So so these drugs can be of choice. If somebody is exposed to radiation, if we have a database, then it will help clinicians to select drugs which can have also radiation countermeasure activity. So with this, I thank a lot, and my apologies because initial few slides I could not connect fully. Thank you, sir.
Hello.
Yes, sir.
Thank you for a very fine presentation. I think you have established the chemical radio protection by particularly by both this tetracycline as well as sodium diclofenac.
Yes, sir.
I just want to know, you said that this act even during the post-irradiation process, there is a protection. So can you tell me what is the mechanism you suggest for its efficacy during the post-irradiation period?
For tetracycline, I can say that because tetracycline prevents secondary infection. It is antibiotic, which is
that's fine.
That's
for
fine.
the other one, the sodium compound.
No, for sodium diclofenac, I have not shown its mitigative potential right now, sir. But probably on HPBL, it has shown protection. Some in HPBL and cytogenetic assay, it has shown. But I cannot comment on mitigative potential right now because for that I have to work on.
No, we have to understand the mechanism by which it acts, probably. So I have one small short question also.
Right, sir.
That is, when you did the Chinese hamster cells, what was the dose reduction factor exactly by the sodium compound?
In which are V79 cells?
Yes, V79 cells.
It was 1.4.
1.4. Okay.
Yeah.
Thank you for your explanation.
Yes,
now the paper is open for discussion. I think I can allow one or two questions only.
Hi, Amit. Good morning.
Good morning, sir.
Yeah. So your radio sensitization part you have shown in the
Yes,
V79.
Right.
What survival level? Because if you calculate the ratio, it will vary from survival level to survival level. Is it at 10% or it is at 37?
No, in V79 cells.
Yeah.
Yeah, in V79 cells, we are actually diclofenac prevents.
That's fine. That's okay. You have shown. That's okay. But then if you call it the prevention factor also, I mean radio resistant property you have shown, right?
Yes, sir. Yes, sir.
Okay. So that factor, if you want to calculate, you have to define the survival level. What is it? D37 or it is a D10?
No, we have calculated, sir. D10, D37 we have calculated.
You are saying that 1.4 enhancement factor.
Yeah, right, sir.
Protection enhancement. So,
it may be it may be based on the ratio of the slopes.
Right, sir.
Yeah, but
it will apply for the entire survival response curve.
Yeah. So the way it is done is that we fix the survival level, and then the ratio is taken. So we have done a lot on using gold nanoparticles and different, radio modifiers in terms of gene expression modulators. So this Pallad University people will be talking about it.
Yes.
So basically, we did all fixing at 10% survival level. I mean,
yes, that's a good idea. It should be in the exponential region purely, then it will be an average figure. I think that's what he has done. Yes.
Yes, sir.
Okay.
So, a short comment. Can I make short question?
Go ahead.
Yes, sir.
Go ahead.
One thing is that when you take in vitro, my questions will be of a novice, the in vitro in vivo correlation. When you take an in vitro dose concentration, what is the expected in vivo concentration or the dose level? That will be important for any extrapolation as far as the effects are concerned in actual situation.
Right, sir. Sir, right now we draw.
My second comment is that you studied at the lethal doses.
Right, sir.
My question would be that if you really want to establish, you said no effects. If you were to take at sublethal doses, LD50 or around so, you might be able to discern some effect, and later on you can do the extrapolations. Anyway, please.
Sir, as far as first question is concerned, that in vitro dose, there is, I don't think there is any mechanism to directly extrapolate in vitro to in vivo. But what we can do is that in vivo can be extrapolated to human use. The reduction factor normally comes as 1/12 of the dose. So that can be done. But in vitro, directly in vitro dose cannot be extrapolated when we select dose for mice, sir. This is the first question. And Second question was regarding, sir,
sublethal doses.
So yeah, I have done experiment at sublethal dose also. In the data probably has not been shown here. So at sublethal dose, our drugs have given almost 100% protection. At sublethal dose,
that is important for the audience to know.
Yes, sir. Yes, sir.
Thank you, Dr. Khalia. And then anyway, you have presented a very nice paper, and also you have demonstrated very clearly both at the cellular level and also by various other assays like the cytogenetic assay and other things, you have established the efficacy of these chemical radioprotectors. So thank you for your presentation. And now we will move on to the next speaker. And next speaker is Dr. Vinita Gupta. So Dr. Vinita Gupta will be presenting the paper entitled Development of Ayurvedic Formulations for Gamma Radiation-Induced Skin Wounds in the rat model. So probably in the, over to the speaker.
Am I visible and am I audible?
Yes, you are audible. Please try to complete in about 12 minutes so that some discussion also should be there after the
Okay,
paper.
sir. Okay. Good morning to all of you. First of all, I would like to thank Dr. R.K. Purohit to give me the chance of presenting my research in this ICRB 2022 conference. The topic of my presentation is development of Ayurvedic formulation for gamma radiation-induced skin wounds, a study in rat model. This work actually we started in year 2018 with the idea of developing an effective radiation-induced model that can mimic the clinical condition, as well as to develop the remedies for that. First, let me introduce you to the topic of this, like what are the possible occurrences of the radiation? What are the possible causes that can induce the radiation-induced skin injury? As we know, like radiation-induced skin reactions, or we can say radiation dermatitis or radiation wounds, they are the significant effect of exposure of skin to ionizing radiation, either during radiotherapy, during nuclear and radiological accidents, as well as during occupational exposures. There are many past evidences are available, documented, which showed that there is a cutaneous radiation injury happened to the humans exposed to these exposures. And when this cutaneous radiation injury is coupled with the...
Hello.
Hello.
Excuse me, madam, sorry to interrupt you. Please do your presentation on full screen mode. And your slides are not moving, madam.
Yes, slides have to move.
Madam, please press F5 key.
Is it visible, sir?
Vanita, it is visible, but you have to take it on the PPT mode.
Ma'am, I'm already on the PPT mode.
Net connectivity problem.
Press F5.
Net connectivity issue aa raha hai.
When you move your PPTs, they are not moving.
Yes.
Okay, share screen. Now it's visible, ma'am?
Yes, visible, but it has to move.
But it is not on the PPT mode.
कब बनाना नहीं चाहिए उसको.
It's visible, ma'am?
Yeah, but it should move on. Okay.
It's moving now?
Yeah, moving.
Okay. Go ahead.
Okay.
Go ahead.
But it's still not in full screen mode.
Full
actually, when I take it in the full screen mode, it is not moving actually. So I think if it is visible to all of you, so we should continue with this only.
Okay, ma'am, you continue that.
Okay. So let's continue with the presentation then. Like what I am saying is like there are the cases of the cutaneous radiation injuries evident in the Chernobyl nuclear power plant accident that happened in 1986. And cutaneous radiation injury itself are not life-threatening, but it causes it impacts the quality of life of the patients due to chronic pain, fibrosis, disfigurement, which leads to lifetime complications of medical interventions. But this ARA, when these skin lesions are coupled with the acute radiation syndrome, it decreases the chances of survivability. Like in the Chernobyl nuclear power plant accident, it was observed that 56 patients got skin lesion along with the ARS, and out of this 56, 50% of the patients died. Even after the follow-up of the 13 years, there are the chronic stages of CRS developed in these patients. There are the other cases also. It's not moving. There are other radiological accidents also happen, like the one in Goiânia, Brazil, 1987, and the Thailand 2000, where there are accidentally the radiation workers or the scrap dealers, they touch the orphan sources containing the radioactive material and develop the significant skin reactions on their body. Now, as we know that the radiation accidents occur very rarely, the only way to get the idea about the radiation wounds are the radiotherapy cancer patients that undergo radiotherapy, and they showed the side effect of radiation as a radiation wound in these patients. So when we searched the literature, we found that approximately 95% of the cancer patients that develop this skin reaction as a side effect, and the reactions usually occur in the form of erythema, edema, dry and moist desquamation, blister, fibrosis, and atrophy. Out of that, approximately 10% of the patients develop the serious reactions. Radiotherapy due to accidental exposures may happen in the radiotherapy, and the patients usually get the high doses of radiation during that period. There is a very good paper by the Coetics et al. That published in 2015. They compiled the data from the 1980 to 2013, and where they have showed that the radiation is the organ that is most vulnerable. And out of the 2390 people they have studied, 46% was found to be the getting the skin reactions. What is the pathology of the radiation-induced skin injury? Skin is susceptible to radiation damage because of the presence of the highly proliferating and maturing cells in the basal keratinocyte, basal layer of the epidermis, hair follicle stem cells, and the melanocytes. Usually, the radiation-induced injury are evident in two forms: acute injury that occurs within hours to weeks and are generally characterized as erythema, dry desquamation, moist desquamation, and ulceration. The chronic injuries happen months to years after the radiation exposure. This table shows that the acute skin effect the patients gets during the localized radiation in the radiotherapy patients are there. The threshold dose for the occurrence of the erythema is 2 gray, followed by the dry desquamation and moist desquamation, which showed that with the increase in the doses of the radiation, the severity of the wounds are also getting increased. Ionizing radiation usually causes the damage to the skin by inciting signaling between the epidermis and dermis, and also brings the many immune cells and the chemokines in the picture. There are other risk factors associated with these radiation-induced skin wounds, like the patient's if the person is experiencing comorbidities, then the severity of these radiation wounds gets increased. So if these wounds are not treated on time, then the skin becomes thin, hypovascularized, tight, and susceptible to trauma or infection, and they may lead to the chronic skin injury. So cutaneous radiation injuries, or we say that radiation dermatitis that happen in the radiotherapy patients, needs a better wound management. Usually what we have seen that there are the conventional methods are being used, like washing with water and mild soap, but these are applicable to eradicate only the erythema. But researchers also use the corticosteroid, hydrogels, and other petrolatum-based emollients, but they all are associated with the some type of reactions. Like corticosteroid results in long-term usage of corticosteroid result in results in thinning the skin. And also in some cases, like where the skin grafting is required, it is a very highly expensive treatment and it is beyond the reach of the poor patient. As of now, we have seen that more than 50 clinical reports are published, reported in the scientific database. And the researchers have utilized so many, interventions, but none of them are in the clinical practice. They are showing varying degree of effectiveness. There are insufficient evidence to support the specific topical agent. So we have tried to bring an effective topical agent that can reduce the radiation-induced skin wounds. So we shifted ourselves to the Ayurvedic formulations that are reported to have a less toxicity. They are cheaper, easily available. So most of the medicinal herbs, they are having the wound healing, radioprotective, anti-inflammatory, antioxidant properties, and we hypothesize that they may prove beneficial in reducing the severity of radiation wounds. So keeping that thing in mind, we approached the Central Council for Research in Ayurvedic Sciences, that is the apex body of the Ministry of Ayush, and played an important role in regularizing the herbal drugs. So we have taken two formulations from them, Jatyadigrita and Jatyaditela. These are the polyherbal Ayurvedic formulations, and most of the components in these formulations are are having wound healing and radioprotective properties. These formulations are registered in the Ayurvedic Pharmacopoeia of India and have the proven clinical efficacy in treating the oozing ulcers, fistula wounds due to sharp weapons, and burn ulcers. So we are utilizing these formulations for the radiation-induced skin wounds, and it is for the new indication. So our aim is to evaluate the efficacy and safety of Ayurvedic formulations against the gamma radiation-induced acute skin injury in rats. And we have also conducted the toxicity studies and tried to find out the mechanistic aspects behind the wound healing of provided by these formulations. The experimental method that we have utilized is that we have irradiated the animal's flabbed skin to the single dose of 45 gray irradiation and observed for the occurrence of the wounds, different sequential appearance of the wound. And on day 14, when the moist desquamation occurred, we applied the different drugs. The severity was noticed and the effect of the drug was seen till day 42. The wound healing parameters were observed as determined by the skin damage score, wound area, and bacterial load. We compared our formulation with the sucralfate and betamethasone. Sucralfate comes in the category of the non-steroidal drugs, ointments, and that can utilize for the treatment of gastric ulcers. Betamethasone is a steroid. The changes in the skin, we have analyzed different markers of the oxidative stress, inflammation, hydroxyproline, myeloperoxidase, and histopathology was also studied. And then to study the collagen fiber deposition, we have utilized trimescence trichome staining and have seen the protein expression using IHC technique and analyzed transforming growth factor beta-1 and alpha SMA. Acute dermal toxicity and repeated dermal toxicity was studied as per the OECD guideline. The results of our study show that when we expose the skin to the single dose of radiation, significant erythema was observed on day 7, and the skin wound was progressed till on day 42, day 14. The skin showed the moist desquamation, and it is observed that 33% of the wound area was found to be moist desquamated. The skin wound severity increases till day 28, where the moist desquamation was found in 66% of the irradiated area. Though on day 42, mild recovery was seen, but the skin still showed the moist desquamation. Now the skin damage score criteria was followed as laid down by the Douglas and Fowler in 1976. Though in radiotherapy, there are different criteria are followed, like radiotherapy oncology group and common toxicity criteria for adverse event. But Douglas and Fowler, these are the skin damage score criteria, which is for the small animals. This is the scoring system comprised of the 15 levels ranging from 0.5 to 3.5, and it showed the detail about the moist desquamation. When we applied our formulations JG and JT on day 14, the formulations were applied twice a day, and we have seen that they showed profound efficacy in reducing the wound area on day 21 itself. That means it prevented the further severity of the wounds, and moist desquamation is prevented. And the further wound healing on day 42 achieved was 92% and 97%. When the sucralfate and betamethasone was applied in line with the formulation, though it healed the wound by 56 and 58%, but the effect was not better than the formulation. To see the presence of the opportunistic microorganisms on the wound, we have taken the swab of the swab from the wound and see that the proliferation of the microbes. And we found that on day 28, the maximum CFU units was found to be observed, which indicated that in the on the moist wound, there was a proliferation of the bacteria. But the application of JG and JT normalized the CFU counts by day 42. Now, we know that the ionizing radiation causes damage to skin by generating free radical, which causes damage to endothelial and epidermal cells. With the damage of the epidermal cells, the inflammatory cascade starts. So neutrophils are the first cells that can arrive at the wound site to phagocytize the bacteria, to clear the infection, and to also generate some cytokines and growth factors. So MPO, which is the marker of neutrophil infiltration, was studied in the skin homogenate, along with the pro-inflammatory cytokines interleukin 1 beta and interleukin 6. We have also studied interleukin 8. It is a chemokine whose main role is to attract the neutrophils at the site of the wound. So the study, all the inflammatory markers showed us that there was a significant increase in the levels till day 42, which indicated that the inflammation is enhanced in the case of the irradiated wound skin tissue, and the application of the formulations reduced on day 21, but the normalized levels were observed on day 42. This indicated that the enhanced inflammation in the irradiated skin actually delayed the wound healing. Then we have seen the oxidative stress markers, MDA, which is the marker for lipid peroxidation, and the antioxidant defense system was found to be highly disturbed, indicated that the skin wounds are highly generating the oxidative stress as till day 42, and which could be another reason for the delayed wound healing. Skin pathology assessed using HND, and it gives us the clear picture about like the pathology of the skin wound. It was observed that on day 7 onwards, there is a epidermal hyperplasia and the dermal thinning. And there is a marked reduction in the hair follicles and the sebaceous glands with the increased inflammatory infiltrates. And with the application of the drugs, by day 42, most of the hair follicles were emerged, and there are the epidermal and dermal integrities are restored. The collagen fiber deposition and hydroxyproline content, which measures the collagen fibers, were estimated in the skin and skin wounds, and collagen fibers actually gives the strength to the skin tissue, and it provides the integrity. It maintains the integrity of the skin tissue. And what we have seen that in the irradiated skin tissue, there was a enhanced collagen fiber deposition was observed, as seen by the blue colored staining, and along with the increased hydroxyproline content. And by day 42, we have seen 60% increase in the hydroxyproline content. Application of JG and J2 reduce the fibrotic complications and normalize the levels of the collagen fibers. In wound healing, TGF beta 1 was, they are released from the keratinocytes and the fibroblasts, and played an very, important role in the angiogenesis, extracellular matrix deposition, and the collagen fiber deposition. Increased expression found to occur till day 42 indicated that it can be directly correlated with the collagen fiber deposition, and the application of the drug though showed the mild expression on day 21, but they normalized most of the levels by day 42. Alpha SMA is a marker of the wound contraction, and we have seen that irradiation increased the alpha SMA expression till day 42, indicating that the wound is not healed yet and is still showing the contraction. But the application of JG and JT significantly reduced the expression of the alpha SMA, and which is can be correlated with the representative images of the wound slides, and it showed that contraction has already happened. The toxicity that we have conducted showed no adverse effects after application of the drug, and therefore we can say that it is not hampering the radiation wounds if we apply the drugs for the longer period of time. So the study showed that the topical application of JG and JT resulted in faster wound healing, and they also reduced the skin damage score by faster reepithelialization. It reduces the inflammation and oxidative stress, reducing collagen fiber, regulating collagen fiber deposition, and also reduce the expression of TGF-beta1 and restore the structural changes in skin. This could be due to the many, antioxidant, antimicrobial, anti-inflammatory, and wound cleansing properties of the formulations. This work we have published in the International Journal of Radiation Biology recently, and the study is still going on, and we need to see some more mechanisms related to the wound healing aspects, like the angiogenesis marker and the remodeling markers. So I would like to thank our director in MAS who gave me permission to present this paper, and my colleagues from INMAS, like Ms. Radha Tyagi and Dr. Sukhveer Singh. And finally, I would like to thank Director General CCRAS for providing the formulations. Thank you, sir.
Okay. Thank you for a very fine presentation. This subject has a very great importance in radiation industry. Particularly, we see very large number of skin exposure accidents in industrial radiography, and also now recently in the fluoroscopy guided interventional procedures also the skin burns are happen now and then. Yes. And I have only one short question, that the dose you have chosen a dose of 45 gray.
Yes, sir.
I think 45 gray, at least in the human beings, I know it causes very severe necrosis.
Yes, sir.
Yeah, and also I hope that you can extend the work also to lower doses, like about 25 gray and 30 gray in this region. That can cause also, that also causes some extent at least severe ulceration and up to that level. I think it would be good to extend it to some few other doses, and also we should control the area, because the healing of the wound depends very much upon the area that is exposed. Larger the wound, the greater the level of injury and more difficult the healing. I only hope that this new technique and use of Ayurvedic preparations, particularly probably in conjunction with the hydrogels, may at least avoid the necessity for skin transplantation and tissue transplantation, etc., and improve the healing. Anyway, thank you for a very interesting presentation. It's open to discussion, but I can allow only one question this time because we are running out of time. And sorry about that.
Thank you very much, sir.
Yeah, okay. Any questions from the audience? One question allowed.
We are all for Ayurvedic drugs. The question can be asked by somebody else.
Okay, thank you, Dr. Kalia.
Yes.
If there are no other questions,
our indigenous products should, if they are found useful, that will be better.
Okay. Anyway, thank you so much for this interesting presentation, and we invite the next speaker and Dr. Ajeshwar Datta.
Yes, sir. Good morning.
Yeah.
Good morning, sir.
Yeah.
Sir, I'm facing some problem. It is when I'm trying to share the screen, it is showing host disabled participant screen sharing. So I don't know. I'm not able to share the screen. Yeah. Now
you will be able to do that.
Yes.
Right,
Yes.
please try.
Yes. So is my slide visible?
Yes, it is visible. Yes.
And it is now in a slideshow.
Yes. Now in the proper slideshow.
Yes.
And full screen. Correct.
Yes.
Go ahead with your presentation.
Yeah. Thank you, sir.
Yeah.
So can I start now, sir?
Yes, yes. Go
Yeah,
ahead.
okay. So today I will be speaking on development of mice model for radiation-induced gastrointestinal syndrome and its application in radiation countermeasure screening. As we all know that whenever there is an exposure to high-dose radiation, whether it is in an accidental scenario or by a deliberate attempt or by any local radiotherapy application, there is it causes a lot of organ dysfunctions that can lead to severe morbidity as well as mortality. So, for the effective medical management of this radiation injuries, the use of promising agent that can minimize the radiation damages are important. So, these agents can be given either before the radiation exposure has taken place, which we called as a radioprotector, or it can also be given after the radiation exposure has taken place to minimize the radiation damage in the cells. And unfortunately, we all know that till date, we do not have any agent that has been approved to prevent acute radiation syndrome in humans. So one of the major limitations or bottleneck that has been considered in radiation countermeasure research is considered to be lack of availability of appropriate animal models. So why we need animal models here? It is very important in the areas where we are working to develop, to understand the biological effect of radiation in humans, as well as we are trying to develop drug to minimize the effect in humans. And we know that we cannot expose human to radiation because it is not feasible, as well as it is unethical. So in this scenario, we need standardized animal models to test these countermeasures. These animal models, they provide suitable platform where we can mimic at least partially the radiation injury conditions, and which can later be used to test this countermeasure agent. And these animal models also allow us to evaluate interinstitutional characterization of new agents. And realizing the importance of this animal model, the US FDA has proposed the animal efficacy rules for those agents where we cannot perform a human efficacy studies. And it says that any efficacy, any molecule which is considered potential, that needs to satisfy the animal efficacy rule, and the efficacy first needs to be established in small animal model, and when the efficacy is proven in the small animal model, it can be taken up further for the efficacy evaluation in the large animal models. So considering the importance of animal model, a workshop was proposed in year 2008 to identify the critical areas that are important for animal model development. And since in my talk, I am focusing only on the radiation-induced gastrointestinal syndrome, I will quickly introduce to some of the recommendations that are directly relevant to development of GI syndrome in mice, in animals. So it was proposed that radiation in GI syndrome in animals can be developed using 4 different approaches. One, the animals can be exposed to high doses of total body irradiation. Alternately, the animal can be exposed to high dose radiation total body, and the hematopoietic system can be rescued by intravenous delivery of the bone marrow. The third approach suggested was to localize delivery of the radiation to the whole abdomen and effective shielding of the bone marrow. And fourth approach was to have the surgical models. In this workshop, the physiological endpoints, the histological and functional endpoints, and the best time point to study these endpoints were defined. The choices of radiation, the best choice of radiation doses, and the species strains, all were discussed at length. And based on all the deliberations from this workshop, it was summarized that any agent that has been tested in small animal if it shows a radiation DMF of at least 1.15 at the LD50 dose, if it shifts the dose response curve to higher radiation doses by at least 1 gray, and if it increases the duration of survival at LD80-10 dose by 50%, then only this agent can be taken up further for evaluation in larger animal to minimize the radiation-induced gastrointestinal syndrome. And before I start sharing the data, I would quickly like you all to know how this radiation-induced gastrointestinal syndrome is manifested. So this is the structure of the epithelium, intestinal epithelium. The dividing stem cells are located at the base of the crypt, and the functional mature cell are located in the villi region. So under normal condition, the stem cell divides and the new cell form, they migrate to the villi, and upon maturity, they sheds to the lumen. But whenever there is an exposure to radiation, the stem cell gets affected, they might get killed, and the supply of the new cell is hindered. So there is no supply of the new cells to the villi, and as a result, gradually the villi starts getting shrinked, and due to this shrinkage, there are different manifestations of different symptoms like electrolyte loss, disruption of barrier, loss of absorptive capacity, diarrhea, dehydration, loss of body weight. The bacteria present in the gut gets free access to the blood, resulting in septicemia, and usually death occurs within 10 days of irradiation. And interestingly, those who survive this acute effect of radiation eventually later start showing delayed effect of radiation, which also compromises the quality of life. So taking into consideration all the recommendations and the knowledge available on the GI syndrome, we tried to clearly define a baseline in our laboratory where we wanted to have a model, a single model where we wanted to study both the acute and delayed effect of radiation. And for this, we selected total abdominal model, where the except the abdominal part, rest other parts were shielded with 5 centimeter lead shields to avoid transmission of radiation to other organs at risk by less than 5%. We selected critical endpoints to study our model, like those who died within 10 days. We studied the survival within 10 days, crypt survival as a histopathological indicator, and bacterial translocation to blood, loss of absorption, and plasma citrulline level as an indicator of functional loss. So the irradiated mice, so we delivered different doses of gamma radiation to the abdomen, and monitored this animal initially for the 10 days to study the acute effect, and those that survived beyond 10 days were allowed to age to study the delayed effect of radiation. So first, post-irradiation, we checked the overall health status of the mice, and we found that there was a dose-dependent decrease in the overall health status of the mice. As you can see from the table, those exposed to around 15 to 16 gray, they showed lower activity, increased diarrheal index, mean body weight loss, increase in body weight loss, and as a result, the disease activity index, which is calculated based on the prevalence of diarrhea and loss in the mean body weight, was also increased in a dose-dependent manner. So the survival study showed, we found that the 15 gray dose was found to be the LD50 dose, and 16 gray, when delivered to the abdomen, all the mice, 100% mice died within 10 days. So we were interested to see, investigate in detail the mice, those were exposed to 15 gray radiation because it was the LD50 dose. And we found that when this 15 gray was delivered to the abdomen, it caused extensive damage to the intestinal epithelium. There was shortening of the villi, loss in the villi number, villi crypt, as well as we found significant decrease in the crypt survival. We also observed increased apoptosis as observed by tunnel staining in the intestinal epithelium, and Ki67, which is a marker for proliferation. There was a reduced expression of this in the crypt region, suggesting that the irradiated mice has a significantly increased apoptosis in the epithelium and reduced crypt cell proliferation. And since we all know that the gut is a repository of a lot of microbiota, we used 16S rRNA sequencing of the fecal DNA, which is indicator of the composition of the gut, and we found that there was an extensive alterations in the composition of bacteria in the fecal matter, and there was a lot of change in the diversity in the irradiated sample at 5 days and 7 days. We found that the phylum, the diversity at the phylum level with firmicutes level, the percent population in the firmicutes were found decreased, significantly decreased in irradiated fecal sample. And we also correlated the breakage in the epithelial barrier with the translocation of bacteria to the blood. The histopathological data correlated very well with the loss in the absorption assay, which we studied by xylose absorption assay. The irradiated mice showed highly compromised absorption. Citrulline, which is a marker for GI injury, and it directly correlates in the loss of enterocyte mass, and here the plasma citrulline level was also found to decrease in a time-dependent manner. So we were confirmed that there was a 15 gray radiation caused a significant injury to the GI system, and since we have used abdominal irradiation, we were interested to see the status of the hematopoietic system as well, and we found that the hematopoietic system was comparatively very well protected when the radiation was given to the abdomen. So as I said that in our model, we were interested to study both the acute as well as delayed effect of radiation. So we further monitored the mice which survived beyond the 10 days time period, the acute effect of radiation. And interestingly, we found that those mice which were looking very healthy till 4.5 months post irradiation started showing a sign of radiation sickness, and eventually they started developing. Here you can see that they had started developing abdominal bloating, loss in the appetite, and they looked very sick. And finally, we had to euthanize this mice. And when we dissected it, we found that the intestine was in a very bad condition. It was very sticky. It was very hard, very difficult to separate. And we found that there were some abnormal structures on the surface of the intestine. And this aged mice showed a clear sign of malabsorption as well. And when we checked the histopathological structure of this intestine, we found that there was extensive fibrosis in the intestinal wall. There was some abnormal structures we observed, like microadenoma, clumping of cells. And when we did mesenteric staining to confirm the fibrosis, there was extensive fibrosis. Here we can see by the blue staining and BRDO staining, immunohistochemistry with BRDO also showed that the mice had reduced proliferative in the crypt proliferation.
So can you complete in about 1 minute?
Yes, I will just rush.
Yeah.
So we could establish that this model, the death we observed was basically only because of the GI failure, and so we were confirmed that the syndrome, we could effectively and successfully develop the syndrome in this mice model. And then we were interested and were happy to validate this model with the radio mitigator, that is trichostatin A. That is the only radio mitigator that is currently under development at INMAS, and we have administered this trichostatin A 1 hour and 24-hour post irradiation. And interestingly, we found that trichostatin A successfully reduced the disease activity index. It significantly prevented the mean body weight loss, and the trichostatin A treated mice survived, almost 40% mice survived till 1 year against 100% death by 6 months. So it also preserved the intestinal structure in a very in a much better way, and it also influenced the bacterial composition and diversity in the fecus, and partially prevented the bacterial translocation to the blood. And since bacterial translocation and irradiation caused extensive inflammations in the system, we were interested to see the expression level of different inflammatory mediators, and we found that the key inflammatory mediators, expression of key inflammatory mediators were significantly reduced. There was less protein modifications, and the prostaglandin levels were also found level in the trichostatin treated mice intestine. And also, since inflammation, also there is a infiltration of inflammatory cells in the inflamed tissue, that we could find that when TSA was treated in the radiation, post-radiation, the infiltration was partially prevented. And the other markers like MPO was also reduced compared to the level were reduced compared to the irradiated sample, and cytokine levels were also found to be, pro-inflammatory cytokines levels were also found to be significantly reduced. So from all this data, we concluded that when we delivered radiation to the abdomen, we could create an animal model to study radiation syndrome, radiation-induced gastrointestinal syndrome, and this model can be effectively used to screen the countermeasure to prevent radiation injuries. And I would like to acknowledge DRDO for funding. This work was undertaken under 2 projects, to our director, different members, different my colleagues at INMAS who have supported in this work, and finally our organizing committee, who has given me the opportunity to present this work in this conference. Thank you.
Okay, thank you for the very interesting presentation.
Thank you.
Your
sir.
model truly reflects the actual effects that we see in the human patients in the dose range of 8 to 15 gray.
Yes.
Malabsorption, fistula, and
Yes.
adhesion of the intestines.
Yes.
And all these things have been documented also in the cancer therapy patients.
Yes. Sir.
So I think your model is very much in agreement with the actual late damage in the human beings.
Yes. Thank you, sir.
See, we can protect whenever there is the advantage of the model is to develop methods to provide protection against the intestinal damage.
Yes.
But when there is a whole body irradiation, the bone marrow itself bone marrow damage becomes a critical cause for death.
Yes.
But when there is only intestine due to the internal radionuclides, etc., internal contamination, in that case, it is possible to probably develop methods for developing methods to protect the intestines by using the model. You can do further research.
Yes.
Anyway, I congratulate you for a very good presentation.
Yeah,
but
thank
I
you,
am
sir.
sorry that we may not allow the discussion now. We should defer it to the tea break.
Okay, sir.
And I think I have, thank you so much for this.
Okay.
And I invite my co-chairman to introduce the rest of the speakers.
Okay, thank you, sir.
Okay. Okay, thank you so much.
Thank you very much. Dr. B.S. Rao, you chaired the session very nicely. Now, let me know, Dr. Purohit, whether we should continue with this.
I think there are 3 more speakers. Probably we should,
Yes.
we can complete.
Should we go for that also? No?
I think so.
Okay, thank you.
There are only 3 more speakers. We will complete them in about half an hour.
Okay, okay, no problem.
Dr. Vinita Gupta to continue introducing rest 3 also.
Okay. So I'm Vinita Shukla from Department of Zoology, Maharishi Daryan University, Rohtak, Haryana. So I take the opportunity to call our next speaker. Is Dr. Shuchi Baghi from INMAS Delhi itself, and she will speak on gene expression based biodosimetry for radiation's emergency medical management. Now, are you ready, Dr. Shuchi? Are you there?
Yes, ma'am. Good morning. I'm ready, ma'am.
Okay, you can start. And specifically, I want to say that being a bit late, so kindly conclude in less time however you can.
I'll try, ma'am. Actually, it is showing a host disabled participant screen sharing. So if you can allow me the screen sharing, I can just listen.
So organizers, we can allow.
Yeah. So by the time it is allowing me the screen sharing, I am Dr. Shuchi from INMAS Delhi, and I am thankful to the organizers, especially Dr. Purohit, for giving me this opportunity, and thank you, ma'am, for inviting me. Before I just start, actually, I wanted to be a part of this conference right from Bikaner, but unfortunately, last week I contracted COVID, and me and my family is still like trying to come into terms with it. So I've just made this presentation in the last 2 days when I could like barely sit. So, and one more thing, I'm not presenting any data here. I'm presenting the idea of what I want to take forward in radiation biodosimetry. And I think this is a good opportunity for me to discuss this idea where there are the like stalwarts of this subject in this conference. I'm still not allowed to for the screen sharing. If you can please do that.
Ma'am, you have been allowed. You can share.
Dr. Shuchi, you can try once again.
Yes, I'm starting it now.
Yes, it is visible.
Can you see it in the presentation? What?
Presentation is visible. Please go for the slide show if possible. Yes.
The topic that I'm choosing today is the gene expression based biodosimetry for radiation emergency medical management. And actually, I think there is a separate session for biodosimetry, but my talk was included in this particular session. So I've just included a little background for it. Like we know that we are continuously... Can I continue? Yes. We know we are like all the time we are surrounded by radiation, whether it is the cosmic or the terrestrial radiation, and also from the diagnostic equipments that are part of that a person is supposed to get whenever they're like going for any kind of diagnosis. And this image I've taken from the Japan Nuclear Fuel Limited that actually shows the kind dose that the person could be exposed, like from like 0.01 millisievert to even 10 millisievert, depending on what kind of diagnostic procedure one can go through. And this is the occupational exposure limit, which is decided by the ICRP, is 20 millisievert per year, which is averaged over 5 years. And the public exposure, it is like 1 millisievert per year. So we know that radiation exposure can be intentional when it is like used for the medical diagnosis or the nuclear tests, and it can be non-intentional, like in case of any accidental scenario, which can actually lead to a radiation emergency. And we know that the first major radiation accident occurred in Chernobyl, and the recent major radiation accident was in Fukushima, and the most highlighted Indian incident, it took place in Mayapuri in 2010, where unfortunately a radiation source was sold to a scrap market, and then we know what exactly happened. So as per IAEA, we know that any event that has led to a significant consequence to people, environment, or facility due to radiation is a radiation accident. And since we are part of DRDO, so we are more concerned about the radiation exposure scenarios that could occur in the armed forces, whether when they are working with the nuclear submarines or in the combat zones in nuclear war, or emergency responders in radiation accident areas, nuclear detonation sites, test sites, or any strategic missions or nuclear weapon tests. So we know that a radiation accident is a low probability, but it is high impact. It is not just the physiological consequence that it bears with. It is also a lot of psychological stress that it brings with it. Whether it is living, the fear of living in a contaminated environment or consuming any contaminated food, fear about the children's future, on any stigmatization, and obviously it brings about the cancerous and non-cancerous radiation exposure risks, health risks associated with it. And death is always a possibility if the radiation dose is very high. So in such a situation where we need a medical management, so this is where biodosimetry comes into the picture. So whenever there is an environment where there is mass exposure is a possibility, like we have seen it in the second wave of COVID. I'm also part of the COVID diagnosis at NMAS. So we have seen it there, that what was the main thing that actually happened. It is the overwhelming of the entire medical fraternity, not just in India, but across the globe. So this is exactly a condition that could arise if there is a mass exposure event. So what is exactly it could lead to is that the overwhelming of the available medical resources, and that time biodosimetry comes into the picture, which can be a very effective tool to actually segregate the people who are like severely exposed, mildly exposed, or even non-exposed, so that we can concentrate all the medical treatment on the people who immediately require it and save as many lives as possible. So this is why biodosimetry is needed, because obviously the general public is not routinely monitored for the kind of radiation they are already being exposed to, and the general public is obviously not wearing the physical dosimeters all the time to actually reflect the wearer's dose. And so there is a possibility of detection of false positives and false negatives in such cases. And there are chances of partial body exposures. And so biodosimetry can forewarn for any clinical developments that can happen later on in life. And it actually acts as a psychological reassurance tool to actually segregate those people who are actually not exposed, because the other physiological signs and symptoms of any radiation exposure is similar to any other medical condition. It is like the vomiting, diarrhea, nausea. So biodosimetry is a very potent tool in such a scenario to actually segregate the worried well. So what is actually required is the triage, where we can segregate these people. And there are different strategies which are followed. There is the networking of the labs which are working in the biodosimetry area, so that at the time of event we can actually join hands and multiply the workforce. And there is the automation of the current available assays and the high throughput assays, which are like coming up as a big way. So the biodosimetry always starts with the clinical dosimetry, with the signs and symptoms, these blood cell counts, and then the IAEA gives these 4 cytogenetic assays in its manual for doing the biodosimetry. And then high throughput biodosimetry is what is very important for the triage. So this is the gold standard of radiation biodosimetry from almost like 60 years. And this is what I have taken from my own slides. This is the dicentric chromosomal assay, which is the specific to radiation, and it has a very low background frequency of just 1 in 1,000. So what it actually means is that the dicentric chromosome appears in like one dicentric chromosome in like 46,000 chromosomes. It has the most established dose response calibration curves. It is most validated and reliable, and it is used across the globe for various radiation accidents. But despite being so the gold standard, it still requires a lot of skill and expertise to actually identify these chromosomes. Even with the automation, you need a manual intervention to actually finally conclude that whatever it is detecting correctly. So if you see, this is the normal metaphase slide, which I've taken from my own slides. This is how a dicentric chromosome looks. And these red arrows that I have pointed out, these actually are not the dicentrics, but they can always be counted as dicentric. So you actually need skill and expertise. You need experienced resource manpower to carry out this kind of assay. And obviously it takes a lot of time because you need at least 48 hours for these the cells to go into the cell division mode. Then you have to actually stop them at metaphase and make the slides. So this kind of assay, despite being a gold standard, is not much of a use in kind of a triage when you need it immediately, because you cannot negate those 48 hours, which it needs for at least the for the cells to divide. So, similar is the case for the other cytogenetic assay, the CBMN, although it is a little easier to score, but it will still be requiring those 48 hours of cell division. And it is also not specific to radiation. So the current assays which are like already available, whether it is the lymphocyte depletion kinetics, it actually requires a repeated blood drawing from the patient. And there is a significant variability in the normal range of the blood cells for the non-irradiated individuals also. Sorry. Even the gamma-H2X assay, we see that the foci, they disappear after some time. And the other biophysical assays like the EPR, it requires sophisticated facilities and equipments. For so they actually have a limited application for the triage purposes. So even the Department of Health and Human Services USA states that we need to deploy radiation biodosimetry devices for any anticipated nuclear or radiological challenge. So this is where the omics biodosimetry comes into the picture, whether it is the genomics, proteomics, metabolomics, or lipidomics, which measures the molecular assays, the dosimeter, the molecular dosimeters that can be taken into account. So I'm focusing on the genomics-based high-throughput assays, and this is coming up in a big way. If you go through the literature, there the major biodosimetry networks across the globe, especially like the RENEP, the Realizing European Network for Biodosimetry, it is taking up regular inter-lab exercises focusing on the gene expression signatures per se. So it is like coming up in a big way. So I'm going to talk about this basic idea which I'm actually working with. So the gene expression biomarker studies basically focus on two areas. It focuses on the identification of radiation responsive genes and signaling pathways, which over 10,000 differentially altered genes in response to radiation are already available in terms of different dose rates, time points, doses, and varied variables. And majorly, these are like the P53 dependent pathways, that of apoptosis, cell cycle regulation, DNA damage repair, which are like the major pathways modulated. And the other the major work which is concentrated on these areas is on the optimization of the confounding variables. Whenever we talk about any high throughput assays, it is always the gaps that are available which comes up in a big way. So one major portion of this kind of a studies focuses on closing of the gaps in terms of the different dose rates, different demographic variables, and analytical variables. There could be what happens if the gene expression in case of combined injury, in case of different radiation quality. So these are the different ways of how these gene expression biomarkers could be focused on. So this is the major work force, the major work area, how it progresses. It can lead to the whole genome pathway analysis, and you can also focus on the candidate genes to make actually a panel of genes that can segregate between exposed and non-exposed. And there are different models used for it, whether it is animal models or the human healthy blood, which is ex vivo exposed to radiation, or the total body irradiated human volunteers for the in vivo studies. So it has a lot of promise, because there are already many genes which are shown to be modulated in a dose-dependent manner, and it covers a good dose range from 0.5 to 8 gray, and it is a rapid technique because it does not require that cell division part to take place. So those 48 hours which the cytogenetic assay takes up, it can be utilized for giving results by the time. And it can be easily performed in any lab that has a basic RT-PCR instrument available. and it can differentiate the irradiated and non-irradiated sample without even having a prerequisite of having a pre-exposure sample matching. It is minimally invasive, it is a high throughput technique, and it has the potential to be developed as a point of care diagnostic, which would be the utmost requirement in case of a mass exposure scenario. So all these things, they actually, it is like given in the literature that it is a strong evidence for it to be used in an alternative tool for early biodosimetry. So these are the latest things which are coming up. It is being used as a high throughput systems, whether using the Kaya Symphony, which gives like 1,000 samples within 30 hours, or another blood-based biodosimetry test, which is done by the ReadyDX system. It has like 18-plex gene expression assays, including the housekeeping genes, and it has a good dose range, like from no irradiation to like 10 gray of radiation dose. It can identify from 24 to 7 days post-exposure with a good throughput range of 600 samples within 28 hours, and it is like getting validated on various models, from the human cancer patients to NHP models to even the non-irradiated human samples. So coming to what I just told the sorry, to the gaps that this technique per se has. So it is not just the pitfalls. I've also tried to focus on the possibilities of how these gaps could be plugged in. So everybody just, whenever you talk about this, the people always talk about the dynamic nature of the gene expression in response to radiation exposure. So there is obviously not one gene can be a biodosimeter for anything. You always need a panel of genes with their own kinetics and amplitudes, which could be required in a combination. Then it is also very pivotal to know exactly the time elapsed after exposure to actually carry out this particular assay. Then there is the time elapsed from exposure to the sample fixation, which is very critical. So now the RNA stabilizing agents are available. The sample can be, the blood can be like frozen for in -20, and then you can always like use the vaccine tubes or other ways available for sufficient RNA to be taken out, and then you can proceed with the assay. Then there is a large discrepancy in identified biomarkers and the producibility of the results. It is there because there is no harmonized protocol yet. There is an observed variability because there are different microarray platforms which are used. There are variations in the experimental protocols. There are different statistical approaches which are used. So it becomes very difficult to actually compare the different studies together. And then there is obviously the scarcity of human population radiation exposure samples. That is why most groups, they rely on human blood, which is exposed ex vivo in animal models. So we also need a strong prediction modeling approaches to bridge this interspecies gap. So what it is, the pitfalls is actually a vast opportunity to analyze the gene expression in different scenarios, whether it is mixed radiation exposures, comorbidities, demographic variables, and other things. So these are the future directions. Many of the studies, when they go for the gene expression, there are some intrinsic differences in the radiation responsiveness of different exons within the genes also. So if you will target on the radiation responsive exons with all the splicing variants which are available, it could still remove the discrepancies that exist in the technique. And then there are studies which are coming up on stable circular RNAs in different pathways, and these are like independently modulated than the mRNAs, and so they are more stable, and they stay for like persistently rise for a longer window of time, so they can also be taken as new exploratory markers. And saliva has also been used, although not many studies are available, but it is still used as one of the non-invasive substrate for the gene expression analysis. So overall, I will just sum up that biodosimetry assessment is a very integral and essential component of any medical triage of any kind of a radiation event. And it is always the integrated approach which works. It will be requiring complementary tools to be used together. And the clinical, the fraternity and the lab network, they all need to join hands so that we can have a multitude of scientists, doctors, and technicians working together in such a catastrophe. So with that, I'll just end my talk here. Thank you so much.
Thank you so much, Dr. Stucci. You were not feeling well. You were coughing continuously. But even then, it was an excellent lecture about the biodosimetry. Now, quickly, one question, if it is
Yes,
there,
ma'am.
then we will shift to the other speaker.
Yes, ma'am.
Only a comment, if I'm permitted, Dr. Vijay
Yes,
Kalia
yes,
from
of course,
Reliance.
Yes, sir, please, sir.
Well, with the COVID recovery process on, you have run a 200-meter race. For the time given, you have completed your task, and it was a very, in spite of that, it was a very lucid presentation.
Thank you so much, sir. Thank you.
Very good.
Thank you,
Very
sir.
good.
Same here.
Hello.
So,
Can I have one question, please?
okay, sure.
Hello. This is yeah. This is Utpal Ghosh from Collagen University.
Yes, sir.
Nice presentation, Dr. Suji.
Thank you.
I just wanted to, just for curiosity, you showed in your slide that EPR can be used, electron paramagnetic resonance, can be used for biodosimetry. So can you say something about this?
Sir, EPR has been a technique which has been long in use for biodosimetry. But what I was telling in my presentation was that it cannot per se be used for the triage mode if it is required, because it requires those big equipments and those sophisticated machinery to be taken up.
For what molecule? What molecule? What should be the target molecule? Which?
Sir, I have never worked on EPR. We do not have that facility with us right now. We are in the process of exploring it.
Let me make a comment here, please.
Yeah, Dr. Ghosh, this is.
Hello. I'm making a comment, please.
Okay, sir.
For electron spin resonance, generally the nail or the hair samples which have very low water content has to be used, and it will provide the data very quickly. But only thing is that the sophisticated instrumentation, ESR facility is not common. That is the main limitation.
Sir, may I add on to it? Now, even the tooth, they tried to do EPR and they got a good correlation, but these studies are very small, study size is very small. So can I ask one question to Shuchi? She's been working on this for a long time.
Please, ma'am.
Yes, yes.
Shuchi, good work. I know you've been doing, so I need not make a personal comment. How can we see the future is in your hands? You people have to take it forward. My suggestion is we should be able to make these essays in such a way that they are very quick.
Yes,
it's like fluorescent tagging.
Yes, ma'am.
Just put a tag and find out what is the dose.
Yes, ma'am.
Can you think about it in gene expressions?
Okay. Yes, ma'am. Actually, I've
have certain genes. Yes. Just if they are altered, have a fluorescent assay. There itself. There you go.
Yes, ma'am. This is a very good suggestion. Obviously, ma'am. Actually, what I have started is that I have taken out the panel of genes. Like we cannot go on with the just deciphering novel things. So I've already taken out the panel of genes and made an array out of it. That is the module that I am working with. So that and I am working it on the dose dependent manner and also different time points. So all those which are like already there, radiation responsive genes. So on different time points and different dosage, how it modulates. So that is how I have already designed my study. So once I'm like through it, and I think your suggestion is, well, I'm very happy that you actually made this comment. So you actually liked the direction that I am following. So it will be like a good opportunity for me to start thinking on those lines. Thank you.
Correct. Future is in your hands. It requires time. Go ahead. All the best.
Thank you so much, ma'am. Thanks a lot.
You need to look for a longer window, because you don't get the sample very quickly, and the signal should remain for a longer time. Such,
yes, sir. Yes, sir.
Gene expressions will only be useful.
Yes, sir. Yes, sir.
So, thank you so much, Dr. Shuchi.
Thank you, ma'am.
I have the opportunity to invite Dr. Shravan Kumar Singh from Mass Delhi.
Yes, ma'am. Good morning, ma'am.
Quickly, you can start up, sir. Please go ahead. Yes, slides are visible.
Yes, ma'am. Is it visible?
Yes, yes.
Okay, okay, ma'am.
Please try to go for full screen, please.
Full screen?
Don't try to move. Sometimes slides will not move. Go to the full screen. F5.
Yep. Already did on the F5.
Just try to go to the next slide if it moves.
Manually, you can go for that. Manually, click the second slide.
Not moving.
It is not moving, I think so. Just
Manually, you can go for that. Keep the cursor on second slide and just
go and click the second side, it will come. Go to the side and click the second one, it will come here.
Click the second one.
you stop slide share and again you go. Once again you do it.
Stop slide share. I'll share again. With this one? Now can I ask?
Ma'am, is it visible?
No, it is in the same mode. Actually, you should stop.
It is visible, but not moving.
Stop share. Okay.
Now again, share screen. Sometimes it works. Yes. Now full screen it is.
Now it is in full screen. You can go to the next.
Now click the next if it is there.
Yeah, I am doing the next slide, but it is not.
Yes.
Moving, it is moving. Very fine, it's moving.
Okay,
yes.
okay. Thanks, sir. So, good afternoon, chairpersons and participants. I would like to thanks to the organization RK Prohit sir for giving me the opportunity to present my research work. We are working on the development of the radioprotected drugs from last 10 years. Especially, we have isolated the metabolites from the radio-resistance bacteria and did a lot of the study and published many papers on this parts. So today I am going to discuss about the identifications of cytokine efficacy biomarker signaling pathway. That is the mechanism offered by the bacterial metabolites IP006 through the proteomic approach. This proteomic approach is very good approach for the quantitative analysis of the proteins expression patterns. And this proteins is used for the biomarkers identification as well as the target identification and for the mechanism studies. So this is the beautiful techniques we have used for the study of our molecules mechanisms. So I'm not going to the details in the introduction part. This is the intentional and unintentional ionizing radiation exposure that alter the cytokine expression profiling, that is the protein expression profiling, that is the gene expression and metabolite. This is the all this manifested into the radiation injury. Our human body is made up of the 100 trillion cells and 25,000 genes, 1 lakh types of the proteins. So this is the huge complex systems, and these are the risk to the radiations. So what is the remedies? What is the solution of this radiation injury? So these are two ways. One is the physical protection, another is the drug chemical protection. So if we're talking about the chemical protections, So there is three terms in the radiation countermeasure is come. That is the radio protector, radio mitigators, and therapeutics. So the already discussed about the radio protector is given before the radiation exposures, radiation mitigators given after the radiation exposures, and therapeutics will be given after the appearance of the symptoms. But these are the radio protector, radio mitigator. These are the mostly are the developed on the classical method based. That is also sometimes called it is the error and trial method, but it's not error and trial method, but it's the some basics. So we are trying to the rational method, that is the modern method. We have to identify the target molecules, then we have to screen against that. So only one radio protector, that is the amorphostines, exist in the world that has a limited applications for the head and neck cancers therapy. So this is the need of the development of the radio protectors. So what is the classical, this is the I'm showing the classical route of the drug discovery and development part, that is the preclinical parts, and this is the clinical parts. And around this drug development is take the time around more than 15 years times, and the cost is very huge, around the $1 billion you can say. But what is the difference between our radiation countermeasure development cases, especially the radio protector development cases? We here is especially we need the animal efficacy rule. Why we need this animal efficacy rule? Because we don't do the human efficacy trials. This human efficacy trials is not allowed. This is ethically not permissible. So this rules is necessary for the development of the radio protected drugs. For this, we have to take the two animals, lower animals and higher animals, and do further study. And for this, for the drug manipulation in the human applications, we have to need the drug efficacy biomarker. That's why the drug efficacy biomarker identifications and validation is necessary part of the radio protected drug developments. So what is we are targeting? We are targeting the NK1 receptor, that is known as the neurokinin 1 receptor, and it is the transient protein receptors, G-coupled receptor that triggered the phospholipase C, and the triggered the calcium inside the cells, and calcium act as the secondary messengers and do the actions in the cells. This is go through the binding, and this receptors play important role, and this is the substance P. This is the neurokinin substance P. Recently, Nobel Prize winners got the working on this substance P. That is the touch and pain receptors. Say this is the so these substance P and neurokinin receptors. And neurokinin, this is the 4 types of the molecules: neurokinin 1, neurokinin 2, neurokinin 3, neurokinin 4, and this is the receptors binding through. We are targeting to block these substance P through the NK1 receptors by using our bacterial metabolites, that is known as the RKIP006, and we have already identified this molecule, that is the NAT molecules. So these actually SP and neurokinin have play a very important role in the especially the neurogenic inflammations. This is the neurotransmitter, so induce the neurogenic inflammation. That is the different from the classical inflammation, that is the cytokine based inflammation, but this is the substance, it is the neurogenic inflammation causing. So we targeting these receptors by using our molecules. So we did the whole body survival against the lethal gamma radiation, that is the 10 grams, by using the oral route formulations, and we have found the very good efficacious molecules, and this is also published and identified, that is the NAT tryptophan derivatives. This already published in the free radical research paper, and further we did the in vitro assays in different cell lines by using the cell survival assay, antioxidant DNA damage protection assays by the human PVC cell lines, in knockout cell line, NK1R receptor, we have is knockout cell line. This is HEK239 T cell lines in which there is no any protections, by which validated this NK1R play the important role in the radio protections. But further, what is the mechanism behind this? What is the network of the proteins involved? We also identified through the proteomic analysis of this work. So in that direction, we also did the in silico analysis. What is the binding protein? We have do the auto-dock analysis, and the binding energy is also, it's the binding is minus 5.7 kilocalorie per moles is the binding energy that shows the effectively binding with the receptor proteins. We also did a lot of the in silico analysis, that is the especially the string, pre-edimity, and pass algorithms. These are the various tools in modern uses. It is the pre-available tools. So by the string, we have also found out that NK1 receptor binding more than the 150 proteins. So what is that, the 115s, which is the sensor protein, what is the transducer protein, and what is the effector proteins? So we have to do the did the ITRAC based proteomic analysis. So today's I'm going to discuss about the mechanistic aspect more of the sense and the cytokine biomarkers of these drug molecules. So there is two method we have used in this present study. This is the ELISA array. ELISA array is nothing new, but it is the same classical ELISA. You know, classical ELISA we have one antigen and one antibodies, but in the ELISA array we use the multiple antigens and multiple antibodies. We have used 12 antigens array. This is the 12 cytokines array in one row, or in one state, and so we use the 24 cytokines analysis through these methods. Another, it is the ITRAC based proteomics and bioinformatics tools we have used for the mechanistic study part. This is ITRAC. It is nothing. This ITRAC means isobaric tag for relative and absolute quantification of the proteins. So this is the tools which is slightly different from the SILAC. In SILAC, the proteomic techniques, we add the probe before the protein isolation during the culture condition. But this is the probe, this is the tag, which after digestion of the protein, we tagging this. And after tagging this, we do
The speaker is not audible, Dr. Vijay Kali.
Hello. Yes.
Yes,
So this is the isobaric track. Sorry. So
your voice is not coming regularly, no? It's just breaking.
I don't know why not moving my slides. There is some interruptions.
Side panel, you can go manually.
Excuse me, is it your internet connection problem?
Oh, sorry, sir. Just I am just again.
Again, share.
So is it visible in moving slides? I'm checking against.
It is visible, yes, but not moving right now.
Oh. Sorry, I'm again trying this, but
Sir, please share.
I shared this. Net is moving, sir.
Shravan, yes, it is moving.
This is good. Okay, fine, sir.
You can start, doctor.
Continue.
Okay, fine, sir. So this is the methodology part, and we have seen the different groups of the controlled drug, radiation, and drug treated groups. This is six animals in each groups, and we have find the different cytokines profilings. These cytokines are the growth molecules and very important for the immune systems and the growth of the blood cells, and especially in Th1 and Th2 response in the pro-inflammatory and anti-inflammatory cytokines. So this is the group of the 24 cytokines we have studied and found that GCSF, it is the highly expressed proteins, and it is the act as a efficacy biomarker. And also we did the SDF, this is the stromal derivative factors. This is the chemo, not exactly cytokines, but this is a chemokines, is a kind of the cytokines that help in the mobility of the blood cells. So these how these cytokines interacting each other. So we have shown in this the cartoon through the string parameters. There is the SDF and GCF. This is the arrow is showing here. That's showing the blue bar, it is showing the binding partners, and this the green bar is the activation partners. So binding and interactive partners here we have seen. Further, we have used the protein tools for these identifications by using the eye track proteomic analysis. We have found the 322 differentially expressed proteins in the GI tracts. This is the study. So this is the 238 molecules is the upregulated, and 142 is the downregulated. This is the, so these are the list of the various upregulated proteins. And these are the list of the molecules that is which have the protein expression value more than the 1.3 or 1.5 and involved in the translation mechanism extracellular matrix proteins. And these are the list of the downregulated protein, that is the 43 proteins, and this is the EPO, and this is the histone, and this is the chromatin remodeling proteins, and the cytoskeletal protein. We have to see these proteins role in the pathways. So this is the tubulin proteins, this is the vinculin proteins, histone H4 protein. This is the highly expressed. This is the four-fold changes is happen in the radiation. This is the red bar representing the radiation-induced proteins, and the yellow bar is representing the drug plus radiation doses. So these proteins altered that affect the function and manifestation of the cells and animal system. So these are the protein 43 proteins involved in the receptor adapter protein, immunoresponse protein, yes, 100 families, integrin alpha families, and cytoskeleton protein, that is the vinculin protein. This is the unique proteins involved in this DNA helicase and histone S2A protein. These are the, so we did the, this is the whole gamut of the proteomes, and this is classified and did the gene ontology study for the molecular functional analysis, cell component analysis, and biological process analysis. Most of the proteins are the binding proteins in the catalytic. Most around the 50% are the proteins, the binding proteins, and the 30% is the catalytic activities proteins, and 20% rest is the transcription factors and other the transcription proteins. So these we have reduced this the pathway, how these proteins work into the pathway. So this is MetaCore software. It is very good software for analysis of the pathway and network of the proteins. So we have seen here is the apoptosis pathways play important radiation-induced apoptosis. How this apoptosis triggered by the radiations. This is showing here, and this is the BDAC protein, and this BDAC protein. This is the pore forming in the mitochondria. When this is the calcium channel. If I am discussing about the calcium, here is the go in cellular and cellular to the mitochondria, and this calcium deposited in the mitochondria, and mitochondrial inner membrane is swell up and burst. And after bursting, this is the MPTP pore, this cytochrome C is released. This is the thermometer, red thermometer, showing that this is the experimental protein, highly expressed protein. This is the differential expressed proteins. This is the upregulated protein. So these are the thermometers showing the proteins in highly expressed and involved in the mechanism of the apoptosis. So this is the one pathway which radiation trigger the apoptosis pathway, and another how this regulate the cell cycle pathway. We have already discussed a lot of the things about the cell cycle arrest. Cell cycle arrest. This is the 4 types of arrest: G2 arrest and G2M arrest. So these 4 type of arrest, how this govern through our these radioprotective molecules. So this is the class of AKT pathway, TAC and MAP3 kinases, and activation of DNA damage triggering through the ATM HUSP53. Main important thing is that this is the 1433 proteins. This is the all this 43 all 43 protein is highly overexpressed and involved in the regulation of the cell cycle. This is the especially unique and interesting proteins, and governed through the CHK2 and CHK2. This is the cell cycle checkpoint regulators and cycling dependent kinase. This is CDC25 and CDC25. This is helping G2M checkpoint controls. So this is the beautiful pathway which is representing the mechanism of the drug radio protections. Another is the this network proteins which shows the antioxidant defense system. This is the antioxidant defense system in cytoskeleton remodeling proteins. So these cytoskeleton remodeling protein especially involved in this the HSP 90, and this is the heat stress factor. This is act as the transcription factor which modulate the microtubules like microtubule proteins in modelings. Another, this is the beautiful showing the SOD. Superoxide is the classical antioxidant defense systems, glutadioxine, thyrodoxine. These are the proteins which is highly expressed, that's shown by the thermometer, red thermometers. These involved in the modulation of the microtubules protein. So antioxidant in these the cytoskeletal remodelings help in the radio protection parts. So now I'm going to conclude through this proteomic analysis, we have identified the various key proteins which involved and show the mechanistic pathways, signal transduction pathways. And these studies shows that RKIP006 an effective radio protector against the lethality induced by the gamma radiations, and its pre-treatment overcome the lethality by improving downstream mitochondrial response, antioxidant, and regulation of the signal transduction pathway like cell cycle and apoptosis. After this study is also very helpful for the identifying of the biomarkers. We are trying to validate this protein biomarkers through the ELISA and through the others antibodies by using like GCSFB, using the antibodies against this, and the proof that this is the no any survival get if the use the anti-GCSF antibodies. So this is the study, and further we have also did few experiment on the monkey. This is the first time we did the radioprotective efficacy test on the monkey at the NII with the collaboration with the NII, and get the positive response, good response. That is our plans. So I would like to thanks to everyone for listening to me. And I acknowledge my directors and our group head, Dr. Rajkumar sir, and my students who involved in this work. So thank you very much. If you have any questions, you can send the mails on the sravanarvi@gmail.com. Thanks a lot.
Thank you. Thank you very much, Dr. Sir. It's a nice gesture that because we are running late, questions they can be asked directly to the mail anyway. So if there is any question, very specific question.
Can I have one question, please?
Yes, yes, sir.
Quickly, Dr. Sir.
Yeah, Dr. Sir, it's a nice talk.
Thank you, sir.
So I'm just asking you the mechanism of inhibition, means mechanism of protection from radiation. This compound, what is that compound?
This is the net molecule RKIP006, sir. This is bacteria metabolite. Fine, sir.
How does it interfere the mitochondrial membrane potential pathway? Means whatever you shown, it is well known that the gamma radiation, it triggers the fall of mitochondrial membrane potential.
Yes.
So do you have any idea about this? How does it interfere the electron transport chain in the mitochondrial pathway? Possibly that will give the mechanism, because that is the start of apoptosis.
Yeah, thank you, sir, for asking the questions. This is very important questions. As we know that this is the radiation damage two ways. One is the direct method, direct DNA damage. Another, the route, it is the free radical generations. So this is the huge free radical generations, and there's the secondary, you can say. This free radical alters, this is the ruptures the mitochondrial membrane. And this is promote the calcium. Here be shown in the data. I don't know you have seen in the slides. I don't know it is appeared or not appeared. But in the slides we have shown that here is the PPIF and MPTP complex, NANT and BDAC. So these by using these antioxidant enzymes, reducing the load of the free radicals. That's the one way here is we get exactly how it is inhibiting. This is not clear exactly, but this is the process by inhibiting the calcium and the antioxidant. This is the main
so scavenger. It is a scavenger of free radicals. It is just neutralizing the
here I am not showing about the scavenger part. Here I am showing the antioxidant defense part. That is the thyroidoxin and glutaredoxin parts. That is the major. You can see in here is the upregulated protein. This is thyroidoxin protein and glutaredoxin proteins and SOD parts.
Can you show the structure of this molecule? It means the reason I am asking is that since this is a small molecule, it may interact with the proteins that are in the electron transport chain in the mitochondrial membrane.
Yes.
So other than your this hypothesis, it may interact with those proteins and thereby.
Yes, sir. You are right, sir. I agreed, sir. This is so therefore, sir, here in the map, sir, in the pathway map, we have shown the HSP90, HSP70, and this is the one transcription factor HSF1. So by this free radical, the folding up the proteins triggered by the proteosomes. Proteins is also triggered. These proteosomal proteins engulf that proteins and eliminate the protein. So exactly we can't say, but this is the, because these are the proteins are the so indirectly we can say this is the route by protecting the mitochondrial protein and electron transport chain proteins. Okay. So by which they are protecting the radiation injury effects.
Okay, thank you.
So
thank you, sir.
Can I ask one question?
Yes, sir.
Okay, someone, I have one question because in relation to cytokines, there is questions arise regarding the extent to which radiation response and inflammatory cytokines mutually influence each other, particularly through ROS generation. Because we know that ROS has generally short lifespan. And so, for example, in relation to NF-kappa B activation, normally NF-kappa B, the radiation dose required to activate transcriptional response probably by NF-kappa B and another pro-inflammatory pathway is of interest. A lot of people are working on that. But normally it is said that around 7 to 10 grays are required to activate NF-kappa B mediated immune cell differentiation. And this is the dose at which also pro-inflammatory cytokines are also released. So there are some studies in which this dose has been shown to also stimulate the production of pro-inflammatory cytokines. So there is how much, what do you think is that, what exactly should be the, what exactly is the response between radiation response and inflammatory cytokines? How do they mutually influence each other? Particularly because through ROS generation, since we are working on radiation, so particularly through ROS generation.
Yeah, this is also triggered. These reactive oxygens species also trigger the expression of the cytokinins by the balancing the TH1 and TH2 response. So that is the TH1 response in which the IFN gamma and IL-12 TNF alpha, these are involved in that. That is the inflammatory sense, you can say, that is involved in the innate immune system. In innate immune system, that is the macrophage cells, that is the neutrophil cells, other these are the cells involved. In macrophage cells, these ROS, whatever you are talking, this ROS is very effectively triggered these cells and affect the secretion of the these cytokines. So yes, your concern is, I think it is valid according to our data, and this cytokinase also expression is also altered as we have seen in the ELISA array. So this is the way.
Yeah, thank you.
Thank you, Dr. Shravan Kumar Singh.
Thank you.
Very nice lecture. Actually, discussion it is required, but time boundation it is again a problem. It was a very nice lecture. May I call Dr. E. Himlatha?
Thank you, ma'am. Thank you.
Okay. Is she there, Dr. Himlatha? Are you there, Dr. A. Himlatha?
Yes, ma'am.
Next lecture?
Yes, ma'am, she's here.
Because her name is not visible.
Can you hear me? She is joining from here. She is not online. She will be presenting from here.
स्लाइड्स कैसे मूव करें? स्लाइड्स चेंज करें, दे दिया आपने?
So now we will be having the lecture.
I think she is joining.
Yes,
Trying to join, yes.
Let us see. Actually, this internet also it creates problems sometimes. So Dr. A. Himlatha, she will be speaking on evaluation of out-of-field dose associated with flattened and unflattened X-ray beams using Mosfet detectors. So let us see. I think she has. Are you ready, madam?
Yes, ma'am. Yes, ma'am. We just connected.
Okay, okay.
She is uploading her PowerPoint.
So in this particular our session, so many lectures were there and all were mostly different from each other. Different fields were there. So I think this is the beauty of any seminar, that we are getting information from all sectors, from all fields, even if we are not working on that particular field. So that is a remarkable thing in this particular seminar, I think. Okay, I think she has come on the dais. So Dr. Himlatha, are you going to start now?
Yes.
Okay, no problem.
So my presentation is about evaluation of out-of-field dose associated with flattened and unflattened clinical X-ray beams using Mosfet detectors. So this is a preliminary study I have carried out in the clinical medical linear accelerator, that is in our radiotherapy department. So what is the purpose of the study is that as we know that so many modern technologies have happened in delivering radiotherapy treatment and also in the treatment planning system. But this improved that conformity or improved modern technology still it is not mitigated the dose to the out of field organs. So the physicists are in way to find the how to reduce the dose to out of field organs. So this is the one of the method we are measuring the out of field dose. So, and we are finding the way how it can be reduced so the patient can be benefited.
कैमरा सेलेक्ट कर दो शुरू से करें
वो नहीं
अब करें हो रहा है
Introduction. So as the clinical use of flattening filter-free photon beam increases in radiotherapy, the need for in-depth characterization of triple F beams is arisen due to the inherent differences in beam properties from the conventional flattened beams. So the triple F is one of the advanced treatment modality available in the linear accelerator machines. So the reported benefit of the unflattened beams compared to the flattened photon beam is that it is very small. Compared to the flattened photon beam is at increased dose rate, reduced scatter and leakage radiation, and a reduction in the out-of-field dose. So what is the out-of-field dose? It is defined as the observed dose that is outside the radiation treatment field border. So the out-of-field doses arises where it is coming is that it is a leakage radiation from the head of the treatment unit and the scatter radiation from the collimator head and beam modifiers. Also, it is contribution from the internal scatter within the patient. So the out-of-field dose may be clinically significant. So when it is significant, when the dose to the fetus or to the organs with low dose tolerance are nearby the critical structure, nearby treatment field. So it is also relevant when considering the risk of second malignancies or the potential failure of the implanted electronic devices like pacemaker of the patient with the pacemakers or defibrillators. In that case, we have to reduce the dose to these devices and dose to the fetus or other critical organs. So there are due to unknown accuracies in the out-of-field dose calculation with the commercial treatment planning system that we used for treatment planning. So it is essential to assess the out-of-field dose through the phantom measurements or Monte Carlo stimulations. So my aim of the study is that to evaluate the out-of-field dose associated with flattened and unflattened X-ray beams using the Mosfet detector. So Mosfet is a metal oxide semiconductor field effect transistor detector used in for radiation dose measurements. So this is the importance of the flattened and unflattened X-ray beams. So here we can see that the first picture is the radiation beam without the flattening filter, and second one is the radiation beam with flattening filter. So initially, most of every machines it comes with a flattening filter to flatten out the beam so that we will get a uniform dose distribution in the treatment volume. Later on, the flattening filter is removed to increase the dose rate so that we can reduce the treatment time. So the first picture is the dose distribution in the treatment field without flattening filter. So the material method and used for this study is the linear accelerator machine, that is medical linear accelerator machine, the true beam machine, and the beam energy we have selected for the measurement is 6 and 10 MB, flattening filter beam and without flattening filter beams. And the detector used this metal oxide semiconductor field effect transistor from the Canada, Best Medical Canada. And the chip, it is the Mosfet is nothing but it is a measurable device. It is an electrical device with a silicon chip of 1 mm square, and the active area is 0.2 mm into 0.2 mm. So it is a device used to this So this is the device, and this is connected with the remote dose verification system through the mobile, through the wireless Bluetooth system. And the phantom is solid slab phantom used, and it is made up of the dimension is 30, 60 into 20 centimeter cube. And the method of measurement is that the measurements are carried out for the 3 different clinically relevant field sizes, that is 5 by 5, 10 by 10, and 15 by 15 centimeter square, under the depth of D max 5 centimeter and 10 centimeter. So this is the schematic diagram showing how the measurements were taken. And so from the field edge, we have taken up to the 30 centimeter from the field edge. What is the contribution from the leakage and scatter radiation? So from the field edge, it is taken up to 30 centimeter. And for 3 depths, we have taken D at the depth of D max 5 centimeter and 10 centimeter. So these are the results of our study. And for the depth D max and for the 5 centimeter and the 10 centimeter, the out of field dose from the field edge, it is shown that 6 MV that is for flattened beam, and for unflattened beam, the unflattened beam, that is out of field dose or leakage or scatter radiation associated with unflattened beam is lower than the flattened beam. So it is the advantages of that triple F beam. So it is proven for all the depth of 5 centimeter and depth of 10 centimeter in both 3 measurements. It is shown that the unflattened beam have a lower scatter and leakage radiation compared to the flattened beam. So similarly, the measurement is carried out for the 10 MV flattened and unflattened external beam. So in the 10 MV, that is in the higher energy, with the higher energy also, the triple F beam is associated with the lesser scatter and leakage radiation compared to the flattened beam. So this is one diagram showing the comparison between the 6 and 10 MV flattened beam, unflattened beam. So here we can see that the higher MV have a higher energy having a lesser leakage and scatter radiation compared to the lower energy, because lower energy will have a greater contribution of leakage and scatter radiation compared to higher energy. So discussion part, from this study, we have observed that out of field dose, that is scatter and leakage radiation from the head and the other parts of the machine, and it is associated with 6 and 10 MV flattened beam is higher than that of unflattened X-ray beam, and it is also decreasing with increasing distance from the field edge. So when you're going away from the field, the out of field dose is decreasing, and the field size is decreased. When the field size is decreased or the treatment volume is decreased, the out of field dose is decreasing. So in the modern radiotherapy, the treatment delivery is feasible without returning filter for IMRT and stereotactic radiosurgery treatment. So in the advanced treatment like IMRT and SRS SRT, now we are more preferring to give treatment without flattening filter, because it the advantage of dose rate, we can deliver this treatment within a few minutes with a triple F beam, because it few seconds. Because the triple F beam have a higher dose rates, nearly two to 3 times higher dose rate with the triple F beam. So triple F beam we can deliver nearly 1400 to 2400 MU, means MU means nearly 25 centigrade and 25 gray can be delivered in a minute. So in addition to drastically increasing the dose flattening filter modality, it also reduces the out of field dose as highlighted in the results. So because it reduces the head leakage, because less target current is required in the triple F mode. Similarly, collimator scatter also reduced, because the flattening filter is no longer source of the scatter. Since the flattening filter is removed, the main contribution from the collimator scatter is reduced. So conclusion, so the dose to the out of field organs at risk and electronic implanted devices like pacemakers can be estimated using the measured out of field data sets. So it is not suggested to rely on radiotherapy treatment planning system data instead of measurement values, since it is not commissioned for the out of field dosimetry. So radiotherapy treatment planning system, we use it for the planning of radiotherapy patients. So that data can be relied only for in-field treatment volume, how much dose is going inside the treatment volume, but outside the treatment volume, how much dose is going, it is not exactly commissioned in the treatment planning system. So from the TPS, we cannot estimate exactly what is going outside the treatment volume. So in addition, the mobile Mosfet used is compact, and it has a rapid online readout and lightweight, and it is appropriate for doses assessment in the out of field region. So the triple F beam is most beneficial in terms of reduced head leakage, and is therefore most advantageous for cases using higher energies smaller fields, and intensity modulation. And it also offers the greatest dose reduction far from the treatment lead. So strip delivery is an improvement in modern radiotherapy. So it can be used for IMRT treatment delivery, like advanced treatment for SRS and SRT. It can be implemented. So these are the references we have used for this study. And I wish to acknowledge my guide, Dr. Arun Chandra, and my department radiotherapy and radiological physics department, and R.K. Purohit sir, and other organizing committee members for giving me this wonderful opportunity. Thank you.
Thank you very much, Dr. Hemlata. It was a nice lecture. Any question? Quickly, one question, because we are running 1 hour late. Anyone? Offline, online, whoever want to discuss anything? One question only. Thank you very much, Dr. Hemlata.
Thank you.
So I thank other chairperson, Dr. B.S. Rao. I had the opportunity to call here Dr. Pratap Singh because it is a long session. Are you there, Dr. Pratap Singh?
Yes, ma'am. Yes, ma'am.
Okay. I hand over the mic to you, please.
Yeah, thank you very much, Professor Vinita Gupta. It's a matter of great privilege to thank all the participants who have joined this session online as well as offline. The third session on clinical radioprotection was chaired by Dr. B.S. Rao from Mumbai and Dr. Vinita Gupta from Rohtak. I'm very grateful to both of them from all the organizers that they very smoothly run this technical session. I'm also grateful to Professor Eva Bezek, who is Director Center for Translational Cancer Research, UniSA Cancer Research Institute from South Australia, and the team in MAS, which included Dr. Amit Alok, Dr. Vinita Gupta, and Dr. Ajas Pratap, Dr. Shuchi Bhagi, and Dr. Shravan Kumar Singh. We are very grateful to them that they all participated and their lecture was very well received by the audience. I'm also grateful to Dr. Hemlata from SPMC, Bikaner, for delivering her lecture. And I'm also grateful to all the audience who have joined online as well as offline, and all the faculty members of Tumor College who have participated wholeheartedly to make this international conference on radiation biology 2022 a success. Thank you very much from the bottom of my heart. Thank you.
Okay, thank you.
Thank you. Thank you, Dr. Pratap sir. Today, in this session, total 7 presentations, out of which 5 presentations in MAS, Delhi. Now, token of respect, I will invite all the faculty members of zoology. Please come on the dais.
मैडम वो दोनों आ जाते हैं एक साथ कैमरे में इसमें वो अब की होगा वो कटेगा चलेगा
Okay, I think we declare the session closed.
Yeah.
We can.
Dr. Rao, Dr.
Okay.
Rao.
Yes.
On behalf of the organizing committee, including my own behalf, I convey my sincere thanks to you, sir. I would like to convey audience, Professor Rao, Dr. Rao is a great scientist of BRC. He visited our college in the year 2004 when you organized the conference. So still I remember.
Yes,
you came
EMSI.
here,
Yes,
yeah,
EMSI
you came
meeting.
here along
Yes,
with
yes.
Professor KP Misra.
Yes.
I invited Dr. Misra also, but due to health, he couldn't come. So I am very happy, sir. Even at this age, even you are so active. The youngsters should learn lesson from your Professor Rao. Dr. Vinita Sukla, I am very happy to see you, madam. Thank you very much. She came here so many times to conduct the PhD Viva of my student, and still I remember in the Hotel Sagar, we felicitated Dr. Madam. Still we remember you. Thank you very much, ma'am. In spite of your busy schedule, you could make it convenient to be with us. Thank you so much. Thank you so much. Thank you, Dr. Pratap. He's a great wildlife specialist, great scientist, senior professor of the department. Thank you very much, ma'am. Thank you.
Okay.
Thank you.
Thank you so much. Thank you so much for inviting us. Yes.
Yeah. Shall we start the next session? Thank you so much. Thank you very much, madam. Okay, please.
Okay. So I'm now leaving. So I'm leaving. It's not leaving. Leave the meeting. Okay.
We are running short of time. I would invite Dr. Dipti Srivastava, ma'am. Please come over here, Madam Dipti, madam. She's the co-convener, senior professor of the Department of Zoology. Madam, you convene the next session. You invite the chairpersons and the rapporteur. Mr. Adyaman is here, assistant professor of the Cancer Hospital. Yeah. Ma'am, Dr. Dipti Srivastava, you convene further this session. Because I think Dr. Kretz is online from the Germany. Yeah, chairperson, United Section of this.
For next session, I would like to invite Dr. Vijay Kalia as chairperson, Dr. R.K. Purohit as chairperson, and Dr. Athiaman for reported. Please, Dr. R.K. Purohit, take your seat.
Good afternoon. Thank you, Dr. Dipti and the Honorary Secretary, Dr. Aromatic, for giving me the opportunity to chair the session. Today, this country is so busy. Today, Dr. Kalia is here, Professor Kalia. So, first of all, I would invite to Dr. Kat K. Dr. Kat from Department of Biophysics, Darmstadt, Germany. He could speak on the targeting cellular metabolism for sensitized cancer cells to heavy ion irradiation. Dr. Kat, welcome to deliver your talk.
Okay, thank you very much. Can you see my screen?
Yeah, you can see.
Okay. So now you should see the main slide. So thank you very much for the invitation that I can present our work at your conference. And as you already heard, I will talk about our project with the title Targeting Cellular Metabolism to Sensitize Cancer Cells to Heavy Ion Irradiation. And yeah, so I'm working at the GSI Helmholtz Center for Heavy Ion Research in Germany. And we focus on particle irradiation. That means we do our experiments not only with X-rays in terms of cancer therapy, but we also use particle irradiation. And one part our lab works on is to study how DNA is repaired after it was damaged by heavy ions. And a second project that we started in 2020 is that we want to improve irradiation therapy by combining it with inhibitors that attack the cancer cell metabolism. And first, why do we use heavy ions for cancer therapy and for our studies? Because it's or can be more effective than X-rays or gamma rays because it deposits the energy at a targeted area of the tumor, for example. As you can see on the graph, when we look at X-rays, as soon as they enter a tissue, they start to deposit energy into the tissue when they pass through it. On the other hand, when we look at heavy ions, when they enter a tissue, they first deposit only a very low amount of energy, but when they slow down, then they release a lot of energy. So that means when the tumor is in that area, we can really target it that the main energy is deposited in the tumor and not in the healthy tissue. For example, when we look at gamma rays, we have like many beams penetrating a target, but they do not carry a lot of energy. So it's like a water hose with a soft water beams. Still, we can use it very well to treat, for example, brain tumors. So we can hit the tumor in red with a high dose of irradiation, but still the remaining tissue is also hit by a lot of energy. And that is especially for a brain not so good. In contrast, when we use heavy ion beams, we have a targeted beam that carries a lot of energy. So it's like a water hose with a very strong water beam that can do much more damage in the target area, as we can see here. We also hit the healthy tissue, but compared to gamma rays, still a large part of the tissue is preserved and not hit by the beams. When we look at the DNA damage level, on the left side at X-rays, for example, or beams that carry low energy, we hit the nucleus, as you can see, with a lot of beams. When we look at the DNA molecule level, we see that only single ionizing events are hitting the DNA. That means we have, for example, only one DNA double-strand break that should or could kill the cell if not repaired. On the other hand, when we look at the heavy ion irradiation, we hit the nucleus maybe once or twice with a beam. But when we look at the track the particles leave, we see that there are many more ionizing events, like each line is an additional ionizing event. And also the DNA molecule is hit by many more events. So there's much more damage created. There are like from base damage, single strand breaks, there are several double strand breaks in close vicinity. And this is the difference to low energy irradiation, because these kind of cluster DNA double strand breaks are very difficult to repair, and this makes it cell killing very efficient. Coming to the metabolism, As you know, we need the cellular metabolism to keep the cells alive, to let them grow, but also the metabolism provides the energy and metabolites to repair DNA damage. It also controls the oxidative stress that further could contribute to DNA damage. And a nice part is that the healthy cells and cancer cells, they have different metabolisms. So that gave us the idea that we could try to target the cancer-specific metabolism to sensitize the cells to particle irradiation therapy while sparing, hopefully, the wild-type cells. On this side, on this picture, you do not have to go into the details. I just want to make a point that the metabolism is not so easy. There are many pathways, they are all interconnected. And so it's not so easy to target a specific pathway without affecting other pathways. So this is a point we have to consider in this project. But for the beginning, we decided to target the glycolytic pathway in the cell. On the left side, you can see that a healthy wild-type cell, usually they take up glucose, convert it to pyruvate, and then bring it into the mitochondria for oxidative phosphorylation. That yields a lot of energy, around 32 ATP per glucose. If there is no oxygen present, this pathway cannot take place, and then the cells use the glycolytic pathway to also produce energy, but the yield is much lower with only 2 ATP per glucose. On the other hand, it was shown that the cancer cells always use the glycolytic pathway, even if oxygen is present. That's called the Warburg effect. And we can see that it produces still a low amount of energy. It also uses more metabolites. In the beginning, or at the first glance, it doesn't make so much sense why the cancer cells use this pathway that does not yield so much ATP compared to the oxidative phosphorylation pathway. But on the other hand, the aerobic glycolysis can run 200 times faster than the oxidative phosphorylation. So the cell still can provide and produce enough energy for cancer cell growth. So with this project, what we want to do by inhibiting the aerobic glycolysis of cancer cells, we want to deprive the cells of energy and metabolites. And we would hope for that this affects DNA repair after irradiation, while wild-type cells should survive this treatment better because we are not targeting their metabolic pathway. And at the long view, that should help to improve cancer cell killing, so that also lower doses would be required to efficiently kill cancer cells, and that fewer side effects will arise because the wild-type cells are not targeted by our treatment. To do this, or to follow this idea, we were looking for wild-type and cancer cell lines that were oxidative and glycolytic respectively. And we're using a seahorse device. So you can basically seat your cells in this kind of plate. And the device measures the oxygen consumption and correlates it to oxidative phosphorylation. And it also measures the proton production and measures this or correlates this with glycolysis. And it's a real-time measurement. It's a very nice system. And also you do not have to use dyes or other markers for this kind of measurement. So we are testing a set of cancer and wild-type cells. And the first result we got is that it's not really holding true that the wild-type cells are only using oxidative phosphorylation and the cancer cells are only using glycolysis. It's more a mix, as you can see here. If we look at the, for example, YI38 cells that are wild-type cells, they also use a lot glycolysis for their metabolism, and the HeLa cells, the cancer cells, they are not really glycolytic, they mostly use oxidative phosphorylation. This can be due to the fact that these are cell lines, because they are cultured in an artificial system, so maybe that changes the behavior of their choice of metabolic pathway. Nevertheless, we were choosing a wild-type cell line that is mostly oxidative, and then 2 cancer cell lines that are a little bit more glycolytic and also oxidative to see if we can target their metabolism. And we also had a look at the spare capacities of these cells. So that means if we have a cell that has a certain level of glycolytic activity, when we then block their oxidative phosphorylation, their respiration, we would expect that they increase the glycolytic activity to compensate for this loss of respiration. And this is indeed what we can see with the HeLa cell lines in blue. They have a certain level of glycolytic activity. When we inhibit respiration, they increase glycolytic activity to compensate. But this is not visible with all cells. In red, you can see the cancer cells HT1080. Here, they are already very active. They have a very fast metabolism. And when we inhibit respiration, there is no capacity to further increase this level. Also, when we look at the same cell lines for respiration, we see that both cell lines can increase their respiration rate when we inhibit. The difference we saw between cancer cells and wild-type cells is that the wild-type cells often have a very large respiratory capacity, while the cancer cells have a more glycolytic capacity. So this seems to be a difference between these two kinds of cells. We also had to choose an inhibitor to target the glycolysis in the cell lines. We use 2-deoxy-D-glucose that mimics glucose, but it cannot be converted to pyruvate. And to see how long this inhibitory effect lasts, what we did, we used HT1080 cells, and then we treated them either with regular medium with sugar, with medium without sugar, and with medium that also contained the inhibitor. And after 3 hours, we removed the inhibitor, washed all the cells, and then added a regular medium to see how long the inhibitory effect lasts. And what we can see here in the upper panel is that in green are the control cells, so they have a constant level of glycolytic activity, while the cells in blue without sugar, as soon as they get sugar, they reach also this standard level of glycolytic activity, while the cells that had 3 hours inhibitor before it was removed, that they still need at least 3 to 5 hours before they come close to the regular level of glycolytic activity. This is for our experiments an important point to use it. And in the next step, we combined irradiation with the metabolic inhibition. And as the first example, you can see the HT1080 cells. These cells had a very high metabolic activity, but no spare capacities. And in gray, you can see the wild-type cell lines as they regularly grow. When we irradiate the cells in blue, we see there's a delay because the cells have to repair the DNA damage. They slow down in their cell cycle. In this case, when we add in orange the inhibitor, we see that the cells nearly stop to grow. And when we combine this with irradiation, we do not see an additional effect because already the inhibitor alone really stops cell growing. So, but when we tested the HeLa cell line, what we see here is again in gray, the control growth, in blue after irradiation. When we add the inhibitor, it is not as sensitive to the inhibitor as the HT1080 cell lines. But when we combine irradiation and the metabolic inhibitor, we see that both together really increase cell killing. As a control, I used the HDD fibroblasts. Sorry for this not so pretty assay. We had an artifact problem here with this bump that goes down. But what is important to compare is that the orange line that contains the cells with the inhibitor and the cells that contain the inhibitor in irradiation, there is no difference. So here we can see that there is no additive effect when we combine the treatment. Yeah, and with this, I want to summarize. So basically what we still try to do is to improve cell killing after irradiation by targeting the glycolytic metabolism. In this case, we saw that the cell lines at least do not have a preference for either oxidative phosphorylation or glycolytic activity. It's a mixture, but what we saw is that the spare capacity differ mostly between fibroblast cell lines, wild type cell lines, and the cancer cell lines. And what we also try to do is to improve this effect, this additive effect, by using a second inhibitor that also targets the redox defense of the cells in combination with the glycolytic inhibitor and irradiation. And with this, I want to thank the lab and the people in Bolt that also work on this project. And I want to thank you for your attention.
For very informative talk on the targeted cellular metabolism. What was your aim? We have come to know the DNA damage and cell death and tumor doses on normal tissue tolerance, and what you are using the inhibiting aerobic glycolysis. Very informative talk. We are thankful to you for sparing your valuable time for us. Already we are running short of time. If one or two questions from the audience, offline or online, Dr. Kratz is here, you may ask. How the heavy ions irradiation used in cancer therapy? Dr. Diamond? Yeah, please. Yeah. Ma'am, he's assistant professor in cancer hospital. Dr. Diamond, please. You can use that mic also. You may come here on. Okay, come.
Good morning to all. It's a nice topic to discuss on this heavy ion radiotherapy. Basically, the fundamental difference between ions and photons is that linear energy transfer. So heavy ions have a higher mass, so they create a higher biological effect when compared to the photons, which we are mostly using. The issue with it's not an issue, the commercial issue. It's a very much a costly one, and still India is not going to adapt it. That's the reason that we are not having heavy ion, but this is the best method of treatment. And I wish Madam it's a very good presentation. Thank you.
Thank you. Thank you.
Thank you, Adyaman. Anyone? Offline or online? So thank you very much, ma'am. Thank you very much.
Thank you very much, sir.
Yeah. Now we proceed to the next session. Next talk. Now we proceed to the next talk. Dr. Sucheta Kumari, she is a professor in Indian University of Bangalore. She is the treasurer of Indian Society for Radiation Biology. Here I would like to mention, she also came to Bikaner in the year 2012. I think along with Dr. Bhandari and our whole team came to Bikaner. And I have been to 3 times to Bangalore. Really, they have set up a very good laboratory of radiation biology, and they are in real sense they are working in the field. You need no more introduction, Dr. Sucheta. You are a well-known figure in the field of radiation science. I would like to deliver a talk. Welcome, Dr. Sucheta.
Thank you, sir. Thank you for your graceful introduction. I'm very grateful to you and the whole team who have given us one opportunity to present. And since 2 days, it is going on very well. It is a tremendous work. Sir, before starting this presentation, I would like to thank Dr. A.K. Singh, Dr. N.K. Chaudhary, Dr. Madhubala Madam, and whole INMAS team who helped us to build this work. So they have given us a project, as well as we are developed the lab for accreditation, sir. Thank you, sir. And this lab is going to be a 4th lab and 1st lab in Karnataka. and we are very proud of this, and you know how well we organized this conference on 2018 also. Before 2 times we organized. So this particular work my team has done, that is construction of in vitro dose response curve using dicentric chromosome assay, establishment of biodosimetry facility at Karnataka. This is gives the idea how do we able to develop a biodosimetry lab. So actually introducing biological dosimetry. Biodosimetry is a key process for assessing the absorbed dose of ionizing radiation by an individual, and it is based on genetic endpoints modified after chronic or acute exposure. Among numerous suggested biological endpoints and cellular biomarkers, the assay of dicentric chromosome in human peripheral blood lymphocytes is the best commonly used and is considered as the gold standard. During large-scale radiation emergency, the dose estimation of the victim should be assessed as fast and accurate as possible. First, a triage should be performed by qualified medical staff according to the clinical science. Subsequently, a categorization of the exposed people by dosimetry must be carried out according to their degree of suspect. Biological dosimetry rapid assessment complements the clinical triage by categorizing potentially exposed victims in different ranges of exposure. In general, biodosimetry laboratories can manage only a limited number of victims at one time. Thus, in the case of mass casualty radiation incident, where the management of several hundreds of victims would need to be performed, there is a prerequisite for national or international networking. Interlaboratory comparisons are widely accepted to achieve the homogeneity. During the last decade, several interlab comparisons have been performed. Few of them were focused on the triage. Different studies have been founded in order to improve standardization and harmonization for the different biomarkers of dose. However, we aim to focus dicentric chromosome assay as it is a gold standard.
Madam, your slides are not moving.
Slides are not moving.
Maybe they are network.
Moving here, sir.
No,
just,
you're not. We can't see. The slides.
One minute.
Madam, please reshare the slides.
Okay. Now, sir, are you able to see?
Share the full screen instead of a particular window, please.
Now, sir?
Yes, it's now on full
screen.
It's fine.
Please thank you, sir. Thank you.
Please check the whether moving or not.
Okay, moving. It's not moving.
Yes,
several networks have been recognized to improve dose estimation throughout, such as the Latin American Biological Dosimetry Network, National Biological Dosimetry Response Plan, Chromosome Network, BiodosNet, European Network, Realization of European Network of Biodosimetry, NATO Biodosimetry Group, and European Radiation Dosimetry Group. At the Indian level, a great effort has been made to harmonize the biological dosimetry laboratories. The test can be performed on peripheral blood sample, which include the following parameters: dicentric assay, cytokines, block, micronucleus assay, chromosome condensation assay, and gamma H2A assay. Importance of dicentric analysis. Among various biological dosimetry technique, dicentric aberrations analysis is the method of choice for estimation of accidental radiation exposure in most of the laboratories. It's a gold standard method. Advantage, low background frequency, even 0.001 per cell, sensitivity 0.1 Gray of whole body dose, specificity except radiometric drugs to ionizing radiation, can differentiate acute body exposure to partial body exposure. So by distribution of dicentric plus or minus 1 for whole body exposure. Significance of the study, quantification of radiation absorbed dose and medical management of exposed individuals during radiological accident, suspected overexposure, preparation of untoward accidents like nuclear terrorism. Need for individual in vitro requires very good standardization. Variable effects the dose response coefficients are dose and dose rate employed for in vitro irradiation, culture conditions, background of dicentric frequency, individual variations in scoring, scoring criteria, error bar uncertainties in calibration and curve fitting. Hence, the dose response curve obtained in one laboratory cannot be readily used for dose estimation by another. Therefore, it was recommended that any laboratory intending to carry out biological dosimetry should establish its own dose response data. So, we have taken the ethical clearance to collect the blood samples from the subjects. After ethical clearance, we collected heparinized blood collected from healthy subjects with consent. Then we did the culture initiation, harvesting and fixation, and analysis. So dicentric is fully hands-on technique. This is 4 to 5 days wet lab procedure. Day 1 whole blood culture initiation. Then day 2 colchicine addition. And day 3 we are doing harvesting. And day 4 slide preparation, 5 mounting, and day 6 analysis. So this is the dicentric assay. We can see the centromeres, and that is single centromere. There are 2 centromeres. So dicentric centromeres we can observe. So dicentric analysis and its distribution obtained from the peripheral blood lymphocytes exposed in vitro to gamma rays. So the dose, first we have fixed the dose, different dose ranges, 0.1, 0.25, 0.5, 0.75, 1 like that. And cells scored, we have scored thousands of cells. And out of that dicentric, that distribution of dicentric, we have counted 1,000 cells in different radiation dose, and we observed the yield. And then we also dicentric, that is dicentric observation per cell we calculated. Then we have also the partial or whole body exposure we calculated by U value, how much, and dispersion index also we measured. So by this we understood how much is exposed whole body or partial exposure, and how many cells are exposed to the dicentric observation. So then the next step we observed the interlab comparison. Here our own scientists, Dr. Selvan and Vishak, we made them to analyze the different set of same set of slides by different people, and we observed their counting of dicentric cells are same. Then it is interlab. So we are collaborated by in Dr. N.K. Chaudhary sir and our team did the interlab conversion comparison from the INMAS scientist and from our lab 2 scientists. There also we made, they are observed a correct amount of number of dicentric cells. Then after that, they have drawn the linear quadratic curve and observed the yield curve, and both what they observed is it is almost same. So this curve helps to know the constructed dose response curve. Then we compared our results with the INMAS and NITTE team. They found the counting of dicentric in a different slides compared to the number of cells. It is also came to the same number. And overall summaries, the dicentric chromosome culture technique has been standardized in our lab compared to the INMAS lab. 3 scorers has been identified and trained to analyze the dicentric chromosome. Intrascorer variation did not observe any significant difference from schema Mangalore. Interlab comparison also did not exhibit any significant difference between 4 scorers. In vitro dose response calibration curve has been completed and it is far comparable with the earlier published data. So this is funded by INMAS, this project, and we have successfully completed this project, and we are now completed 90% of NABL accreditation. And we have now so many projects we have taken from the various project supporter, that is for micronucleus assay, dinitric centric assay in various metabolic syndromes. One project we completed with the patient, and now other projects are going on. So here I am very grateful to Madhubala madam and whole team who have given the chance and facility for in our lab. And also Prohit sir has come here and observed our lab. Our scientists are really doing well, and we are very grateful to INMAS. Thank you, madam. Thank you, sir.
Thank you, Dr. Sucheta.
Yes.
Madhubala ma'am, for your comment, please.
I would like to thank you. I would like to, first of all, congratulate NITTE University, and under the leadership of Professor Suchita and Professor Bhandari, this work has taken off very nicely. In fact, in one of the international conference in 2016, this work was conceived, and I asked, I requested Madam Suchita, why don't you take up, this is a work of national importance. And she started from scratch, and today I'm very happy. She is looking for an accreditation.
Yes, sir. Yes,
and she's very close to it.
Very close.
And you know, when you have made this lecture, again, I'm very thankful, because this is an eye-opening lecture for everybody.
Yes, sir. Yes, ma'am.
Whoever wants to join this stream. Basically, if we have to carry out triage under radiation exposure, in should there be any incident, we would be requiring multiple centers. And Professor Purohit, why don't you now make an effort? You know, your college can be the first one in Rajasthan to be accredited. You see, your college has come up now. From the time when I had seen in 2004, 2012, and maybe sometime later, another time also. But now what I am seeing, it has become a wonderful place for work, and your faculty is also ready. Your students are also enterprising. So why don't you start now? This is my proposal. And yeah, you know, wherever support is required, INMAS is there. Suchita, Professor Suchita will also help.
We will help, sir, madam.
As a society, we build centers. what utility this society has to nation. We are using their funds. So my vision is, as the president, is let us have accredited centers all across the country. So this is the comment, and once again, I would like to congratulate, of course, Professor Suchita and her entire team. Vishak was a young scholar when it started. He was doing his PhD, and see, he has become the backbone of this work. Huh?
Yes,
Even
sir.
Tamil
Even
was there in
yes, he was working under the NK Chowdhury.
Came in 14 as a student to international conference. So, you know, it's very heartening to see the youngsters coming up and taking up such work of national importance and seniors mentoring them. Thank you. My comments are. Thank you.
Thank you, madam. Thank you so much.
Thank you, ma'am.
Thank you, sir.
Dr. Kalia, you want to make some comment? Kalia, sir?
No, it's okay. We all know Dr. Sucheta, and she needs no introduction.
Yeah.
And the work is wonderful. You are the man of the conference. You are chairing the session. What is there?
Your blessings are always needed, sir.
Thank you, sir. Thank you so much, sir.
Thank you, Sucheta, madam. Thank you very much.
Thank you. Thank you so much.
Personally, I am always very appreciative of the way I had met her in 2004 in your conference after my lecture, and from there on, if we see today, it has been an exponential growth curve as far as Dr. Sucheta and her group is concerned, and her institute's involvement in radiation biology is concerned.
Thank you so much, Dr. Kalia.
Thank you, sir. Thank you so much.
Professor Purohit,
yeah, ma'am.
You will also take up this work in your college.
I will take your advice into consideration. I will discuss
I
with my sure, ma'am. We would like to
I want
also
this
incorporate.
college to be accredited now. Some quality work should come out. Huh?
Oh, sure, ma'am. Sure, I can assure you, we will take it seriously in the future.
Thank you
very much. Thank you very much for your kind words.
Thank you.
Next speaker is our Professor P.K. Goyal, sir. But due to unfortunate incident, we will not be able to deliver this talk. I convey my regards to ex-president of ISRP, Dr. P.K. Goyal. Now we proceed to Dr. Vinita Gupta is here. Again, she chaired the session in the morning. Dr. Shukla, she is professor at head, MD, University of Rohtak. She has been to Bikaner, and she is a popular figure in all over the country. You can see her in the social media, in the Twitter and the Facebook. And I always visit your page. She would speak on electromagnetic pollution on human health. Ladies and gentlemen, dear students, this topic is very useful for you all. Kindly have patience and listen to the talk carefully. Dr. Shukla, please.
Thank you, Doctor. Thank you. Just you have disabled me for sharing. Please make me permission is to be granted.
Madam, permission is there. You are allowed to share the PPT and unmute yourself.
Yes. It's visible, Doctor?
Yes, it is visible. Perfect. Please go ahead.
Thank you. Thank you. So this is because we are running behind the time. So this is my university, Mahashidanan University, Rohtak, Haryana. This is my department. It is PhD department, and it was established in 2009. I just want to talk about this mobiles and health. Now we are using mobiles. Each and every person, it is having a mobile in hand. So it comes to the mind of my students as well as to my staff that how much, whatever media says, that mobiles, they are not good for us. We are using too much. So is there any, really there is any health effect, or it is just a reason to say that we should not use it much? Then like we are listening, we are just came across that radiations are not good. So most of the time when it comes to radiations, we think that these are concerned with X-rays or something like that, or any other type of radiations. It hardly matters to us that whether we are carrying a radiation in our hand all the time, in our pockets or with us. So that was the reason that it clicks in the mind of us, and we submitted a project in UGC, and it was funded, where we were just thinking of that whether mobiles are having some impact or not. So this risk is there, whether there is real effect is there. When we say that in different RAM, whenever the radiations we are getting exposed, they are causing different type of effect on us. It is all there in literature, that some fatigue it will be there, vomiting will be there. If you are for longer duration, you are open to that. So each and every person knows it. Effective dose is there. What can be the radiation source? Everything it is there in literature. Now, when we go for this human physiology, or you can say in our nearby TGI is there. So in medical college, we contacted Dr. Dhruv Chaudhary and came with us for working on this. So through the literature, like you must have came across that it affects the embryo or the fetus. It affects the cell sensitivity. It shows the genetic effects whenever we come to the radiations. Radiation damage, it comes to the chromosomes, whether it is direct or indirect. It is all through in literature, so I'm not going just passing these slides. At the same moment, the chromosomes, they also get damaged. Hormesis, it is there. And this is the glossary which is available, that whenever we say ki exposure kya hota hai, what is the low level radiations, high level radiations, whether any health effect is there, what is RAM, what is risk, and what is safe. So everything it is available. And till now, like everyone, it is having mobile in hand. It is so much radiations, and media it is also reporting very, you can say high coverage it is there. Before 6 months, that questionable studies on adverse effects of mobile phone radiations, like cell use, tower health hazard. You must be knowing that in many cities, the common people, they were saying that towers we are getting hazard from the towers. We should not keep it in our mohalla, in our particular town area or nearby to our residential areas. Cell phone के विकिरण बच्चे के लिए खतरा, that sparks radiation fears from mobile phone towers, radiation से सिहर रही प्रकृति. So many media coverage it is there. Mobile radiations और उसका असर. Cancer study ordered into mobile phones to the court because lot of literature or lot of media coverage was there. So you must have come across such type of this media coverage. This was very popular article that while talking on the mobile, the ear it caught the fire. Now this is the tower which can cause the radiations from CDMA. We are going to 5G even. Like last night, there was a news that near the airport of US, they are using 5G, and airlines, they are causing problem for that. While using any type of mobile. So this everything that through media we came to know, through people we came to know that mobiles, they are, you can say, affecting us. So it clicks in our mind to work on that. So whenever we purchase a mobile, it is written as SAR on that cartoon in which you purchase a mobile. So this SAR, it is a specific absorption rate, and this is very specific term which has been given that whenever how much radiations they are going inside the body. So if we go for these developing countries or the developed countries, difference is there. Like we people, sometimes we go to the market and just purchase any type of mobile, whether it functions well or not, whether it is of the high sensitive area, or it is having the type of some mark of some reputed company or not, just we purchase it for the use. In developing countries, I'm saying. So this SAR, it is very important that how can it affect the body. So in Israel, this type of study was going on that it causes the salivary gland tumor because you keep the mobile near this salivary gland and it shows the effect. Again, it is showing the young children that some behavioral problems are there. You can notice in your home also. If one child it is on the mobile, you can't call him, you can't ask him for study. So that is the reason. This is again in literature that it affects nervous system, immune system, cardiovascular functions. Even if pacemakers it has been placed inside the body, it can affect that also. Hypersensitivity is there, hip bone density it also get decreased. And finally, it is reproduction. So just we came to know through this literature that whether it is true or not. Sometimes when we say to our students, because we are having MSc student as well as research scholars, we ask them just use mobiles to less time. This is nothing, media to वैसे ही कहता है. So because of that reason, it just clicked and we worked on this particular aspect that whether it is causing effect on the reproduction, which is there in the literature, because no confirmatory results were there till then through our studies. So the factors again, they influence and different factors are there. What is the mass, what is the shape, what is the size, what is the, you can say temperature, fat content of the body. So many effects are there. We can't say that a single mobile, it will affect every person with the similar way. But even then, effect is also there. So we started this particular study in MDU, Rohtak, and we took these objectives. So I will quickly, I will go through these slides so that we come to the conclusion first. So objectives, that is important. And I suggest the youngsters who are listening to me, that they can go for such type of studies. They can elaborate it or they can expand it for a more, you can say, level. So how EMR, they induce changes in germ cells, in somatic cells. With the help of SAM-TEM, we get these results. And also we worked on the steroidogenic output, various hormones. And Comet assay, it was also done. So whether it is affecting or not. So these objectives were selected for this particular part of the work. And when we go for ethical approval, at that moment we put the research design also. So we took a group of the control and second group we exposed for 90 minutes, half hour rest, then again 90 minutes, and the other group took 3 hours exposure, half hour rest, and then 3 hour again exposure. So we used CDMA cellular phones. These phones, they were having the SIM. So we just on it and put on the rat cages. So rat, they were selected, they were male only because of the ethical design. Male were selected because reproductive study, we thought that we will do with female later. Now, first thing when we say that it is the Comet assay, different methodology, you must have seen that literature it is available, so different methods. Through the standard method we used it. We made the slides also with this method. Slide processing was done, then staining was done. Hello assay, it was done with the help of Jenna et al. 2008. Prescribed procedures were there. Hormone assays, they were taken into consideration. Electron microscopy was done, and SAM-TEM we take the help from the AIMS Delhi, because PGI was in our collaboration, so it was easy to go for Delhi. We send this slides to them and then they get the conclusion for us. Then histomorphology to the Pierce method. Always statistics, it has to be involved. Now let us see the results. So you will come to know that when we say mobiles, they are not affecting us. You should not say like that. Just to come across slides which has been made in the lab itself, let us see the Comet. Students, they must be attending this. Comet means the Puchal Tara. So when the nucleus, through the DNA contents, they form a tail-like structure, we say it is a comet. Now let us see, this is a simple type of, you can say normal or control type. Then it is exposed one, it is getting its tail formation, and later it is getting diminished into the total tail formation. So such type of just a representation it can be there when DNA is undamaged, it shows the damage through the formation of this chromatin. So hello assay it was done to confirm it. So these are the healthy germ cells which were there. Those pictures we picked from they were taken in the lab itself. So this is the photomicrograph of control group. It is showing the healthy germ cells. On the other side, in different categories, A, B, C, they are showing the damaged type of cells. Now this cell, it is totally damaged. Whenever this transmission electron micrograph, you can see, this is the normal. Like in your textbooks, you must have seen that such type of very beautiful structure it is there. That when we expose the rats for 3 hours per day up to 6 months, now they show us the defective formation of the acrosomal plate. So I have put the arrow wherever the specific effect it is there. So this arrow, it is defective formation of the acrosomal plate. Now again, this is the control one. And here again, it is revealing that spermated cytoplasm. It becomes very much dark and irregular type of shape of the mitochondria. It is very visible. So beautiful slides are there. This is again a control one. So this is forming a acrosomal cap and this is a beautiful structure. And here you see whenever we expose with the mobiles 6 hours per day up to 6 months, just you can see the vacuolated type of spermatids are there. So many vacuoles they have, you just compare the two cells. Again, this is a regular type of thing. Lamella, it is complex, it is always there. And here you can see totally wing-like. जैसे आप गले में चेन पहनते हैं. So this is called annulate lamellar complex, which has been formed. Again, after 6 hours per day up to 6 months. So we are using more than 6 hours, you can imagine. To scanning electron microscopy. So this is the slide which is showing the control one. Everything it is at this place. Whether you are talking about bleeding cells, mycoid cells, blood vessels, everything it is at the place. And then it is the scanning electron microscope of the rat which was exposed 3 hours per day up to 6 months. And now you can say this type of, जिसे कहते हैं असल में लुगदी type. So these are all degenerating cells in the seminiferous epithelium, which is due to the exposure to the radiations of the mobiles, your mobiles which are in your hand always. Just you can see this is again so clear slide it is there. Now this is showing the smooth surface also, and this is the total structure which is visible in the hollow lumen. It is there whenever we go for the male structures, and now you see after 3 hours per day up to 6 months, this is the totally degenerating cells, debris it is there. Total जो कहते हैं ना कचरा type, and rupture type of sperms heads it is there. Here you can see heads, they are so beautifully arranged and very you can say nice in the control, in which there was no exposure to the radiations. Now this is scanning electron microscope of the control testicular tissue again. Here you can see that total everything it is totally intact also because it is a network, but here it is the total degenerating. So quickly we can go through. You must have come across what is the difference in between upper side it is control one and lower one it is exposed. Now histomorphology, simple dissection to the this type of thing, it is through staining you must have come across. This is very clear cut. Here you can see demarcation through the arrow it is there, which particular area which are showing in the experimental work. So the space it has been increased. These are here they are intact to each other, and here the space is there. If there is anything you can say harsh is there on the microtome, on the anatomy, then it will also influence the physiology. Again here total interstitium, it is very beautiful, cells are there, and in the cells it is specific, and here it becomes very condensed. They are taking much of the stains also. Here again arrangement of the cells in the tubule interstitiums, it is very beautifully placed, and here the total vacuole it is showing, and ultimately the free floating cells they are in between. So you can compare these two slides. Here again, this total placement, it is again very clear, and here you can see the living cells in between, so much vacuoles are there. Same here. It is the same, you can compare. Now DNA damage, it was the slide which we picked up, and this is unexposed, then it is DNA breaks, very obvious, and this is the total DNA damage. Lot of slides were there because he told me that we should stick to 20 minutes. So I was not thinking that one speaker will not be there, but anyway. So on basis of this, like you must have come across that so much difference, so much, you can say, comparative difference it is there in control and exposed one. So on that basis, our medical college and things, we got some standard safety, you can say, precautions. First thing, it is again, as I told you, it should be the SAR value. So SAR value, it is different for that in different countries. So you should go for that. And if it is there, it is written on that it is 0.7 or less, then you should purchase it. Now different companies are there that how much radiations are absorbed by the body. So that thing, to the dosimetry, you must have come across, तो आज बहुत से lecture हुए थे. So we should get that cartoon also. ऐसा नहीं है you go to any particular shop and just purchase it. So we should be aware of this SAR value. Then consider the following standards. Use a hands-free set. You must be having this cord along with this. So your hand should be free and it should be placed at a long distance from the body. So automatically the amount of radiation will be reduced. Then hold it at the bottom. Now question arises that whether it is the prescribed one or not. Through our experiments, हमने ये भी experiment किया था कि lower side of the mobile रखें rats के ऊपर और it should be the upper one. So both comparative studies, through that we came to know that from the lower side, the radiations they are less in comparison to the upper side. So better you hold it from the bottom. Whenever you hold it from the bottom, then ultimately the radiations exposure is less. When the signals are not coming, these are the signals. Other if you can see it is one only, you should not get that connected, because whenever the signal reception strength it is less, it is not good. Then the phone, it reduces the power. If reception is poor, the phone it will use the maximum power and maximum radiations will be expelled. So this also we checked through the experimental process, that what is the, if this reception is not good, then whether it is causing the effect on the rats or not. So one standard method we have used also for that also. And this is a very common type of article, that do not sleep with mobile phones under the pillow. So someone, we just checked this also. If we off the mobile and keep it under the pillow, whether it does affect us, or it is just when it is on and we are placing under the pillow. And it is of our, you can say, surprise that while it was off, even then it was causing the same effect. The reason may be, when we discussed with AIMS person, they was telling that there must be a reason that whenever we switch on the particular set, it just at the same moment it gets started. So there must be some type of initiative in that, some type of, you can say, whenever we get it on, some radiations they must lies there, which is type of dormant radiations. So in both cases, you just keep it away. Don't put it under the pillow, whether if it is off in it. Then use a regular phone if possible. So in offices, at least at our working places, we can use the general type of phones because it is present, it is available to us through the, you can say, जब भी हम बात करते हैं, it is also available. So possibly, if possible, we can use so that radiations, they should not be in direct touch with us. You just hold it, talk to it, and then you can keep it.
Dr. Shukla, kindly conclude by your request.
Sure. Now, children, they are below 12. the children, they get exposed to that media says, and same was the result with the young age rats also. For SMS, these stations, basement stations, they should be away from the residential area. Don't talk too much. The research or the experiment which we conducted, we came across that if you talk till 15 minutes, it is fine. Then you should break the talk, and after that you can rejoin it. And the side effect, that is an indirect effect, that while driving you should not use because it is dangerous for others also. So many accidents can be avoided. So thank you. You should take care from the mobiles. And was the work which was funded by the UGC, so I'm very grateful to them, and Dr. Purit Sivaj who worked on that. At the same moment, I'm thankful to Dr. Purohit and the whole team, all the people who are involved for making me to share my content with all.
Thank you, Dr. Shukla, for being with us. I would like to have, I can allow one question only. Adyaman. Adyaman is an assistant professor in Cancer Hospital. He wants to ask one question only. Adyaman, one query, one question.
Yes, yes. Sir, I will take 1 minute. Ma'am, it's not question at you. Just I want to share my views. Since I am the radiation safety officer of this regional cancer center, and I am often encountered of this question, whether mobile phone radiations are harmful or not. And mostly I say it's not harmful. But ma'am, your presentation has changed my view. Why my answer was no? Why my answer was no is because we work on high level radiations. It means in the mega voltage, 15 up to 18 MV X-rays we are handling. So compared to that, these mobile phones radiations are insignificant in my view. But today your study have revealed there are effects. So students who are sitting here, you should take the information that actually what ma'am has told, you should use the cell phones in a shorter time. That's the fundamental thing I'm just about to explain. The logical answer you should have is, the problem is due to the improper use of mobile phones. Never go against mobile phones. It's a wonderful technology, and today our conference is being conducted successfully because of this technology only. But we should have the awareness how we are using it. Okay. So what is the knowledge we should have of radiation? There are 3 methods to protect from radiation. That is time, distance, and shielding. So you should use the mobile phones smaller, in a shorter duration, and you should keep the distance as far as from the mobile phones or any source of radiation. And shielding we are not able to use in mobile phones, but that is the method we follow in radiotherapy to protect from high energy radiations. As far as this specific absorption rate is concerned, it was a very good point everyone should know. I request you to take your mobile phones and you can check it. You can dial and check what's the SAR value of your mobile. If you are fast, you can take it. You can dial *#07#. It will give you the SAR value, specific absorption rate of your mobile phones. Okay, the allowed limit is 1.6 watts per kg for 1 gram of tissue genes. Right. So in India it is allowed. I think in US and Europe, ma'am has told that it is 1.6 and 2 watts per kg. So these are the things, and mostly using of mobile phones is creating secondary effects. Like ma'am has told that if you are using the mobile phone during driving, it creates secondary effects. But we should not blame the mobiles. We should blame the human how we are using it. This is the point I want to mention. Thank you, ma'am. It's a very good presentation.
Thank you. Thank you so much.
Thank you, ma'am Shukla. Thank you, Adyaman. Our next speaker, Dr. Savita Verma from INMAS. Is Savita is here?
Yes, sir.
Yes,
good afternoon.
My humble request, because we have a lunch session, then the post presentation, then the young scientist, then the very senior professor, they will be doing lecture. Kindly finish it off within 8 minutes.
Okay, sir. Thank you. Good afternoon. Myself, Dr. Savita from INMAS. Today, I am going to talk about screen share. Sir, please allow me to share my screen.
Hello. Yeah, ma'am, you are allowed. You are allowed.
Okay, okay.
Okay, I can see your slides. Please go ahead.
Today, I am going to talk about radiation-induced lung injury and its protection by using a flavonoid, quercetin-3 rutinoside. I will also discuss the possible mechanism of action rendered by Q3R. If we talk about the radiosensitivity of the organs, it's not moving.
Sarah, if not moving slides.
Okay.
Yeah, you can see.
If we talk about the radiosensitivity of the organs, the highly proliferative tissues like the bone marrow and gastrointestinal system, they are highly radiosensitive. Although the lungs are slow proliferating, but they are highly radiosensitive due to their physiology and high oxygen content. Lungs are exposed to radiation during radiotherapy or during the radiation accidents. 30 to 40% of the patient, they develop radiation-induced pneumonitis and fibrosis after radiotherapy treatment. And unfortunately, there is no effective treatment modality which can counter the damaging effect of radiation. So there is a need to develop a radiation countermeasure which can minimize the damaging effect of radiation. The pathogenesis of radiation-induced lung disease is very complicated. First, we will try to understand the mechanism of radiation-induced lung injury. When the lungs are exposed to radiation, there is production of the free radicals. These reactive oxidants, they damage the epithelial and the endothelial cells of the lungs and result in loss of the capillary barrier. Loss of the capillary barrier resulted in infiltration of the inflammatory cells into the lungs. These inflammatory cells, they secrete various kinds of the cytokines like IL-1 beta, IL-6, IL-18, TNF-alpha, etc. These inflammatory cells, cytokines, they causes differentiation of the fibroblast to myofibroblast and deposition of the extracellular matrix, finally leading to lung fibrosis. And it will ultimately lead to the death of the individual. First, we have tried to establish a pulmonary syndrome model for radiation. We have exposed the animal to 3 different doses of radiation, 11 gray, 12 gray, and 13 gray. And we found that 11 gray is LD30 within 120 days, and 12 gray is LD50, and 13 gray is LD100. Then we have carried out our experiment by using a molecule, quercetin 3-rutinoside, which is a bioflavonoid, and it is found in many of the citrus plants, buckwheat, apricot, grapes, etc. This molecule is commonly known as rutin. It is having many pharmacological properties, like it is anti-inflammatory, antibacterial, anti-allergic, etc. This molecule is already in use in clinic for the treatment of osteoarthritis and neuroinflammatory disease. In our experiment, we have divided the animal into 4 groups: control, Q3R treated, 12 gray localized irradiated, and the 4th group, the molecule is injected to the mice 1 hour prior to radiation, and localized radiation is given at the thoracic region, and the study was carried out 4 months after the treatment, because 4 months is enough time to develop the pneumonitis and fibrosis. Since Q3R is a very well-known free radical scavenger, it is a antioxidant compound. So it scavenges radiation-induced reactive oxygen and reactive nitrogen species. Q3R enhances the level of endogenous antioxidant and decline the lipid peroxidation in the irradiated lung tissues. Q3R is also known to inhibit various enzymes which are involved in the production of ROS. By curtailing the production of these reactive oxidant, Q3R significantly minimizes cell death in the irradiated lung tissues, which were detected by using the tunnel assay and annexin 5-FTSE staining. Exposure of radiation causes severe pneumonitis and fibrosis in the irradiated lung tissue. As you can see here, in the irradiated group, the lung is congested and having infiltration of the inflammatory cells. This blue color staining, this is indicating the deposition of the collagen because of the radiation exposure. But in the Q3R treated group, we can see here that the lung inflammation and the fibrotic changes are comparatively less. That means Q3R, it is protecting the structural changes in the irradiated lung tissue. As I have discussed earlier, that radiation causes damage of the epithelial and the endothelial cells. which resulted in activation of the intracellular cell adhesion molecules ICAM1. ICAM1 help in the recruitment of the immune effector cells like macrophages and the leukocytes. Q3R inhibited the infiltration of these inflammatory cells, inhibited the expression of the ICAM1 and thus prevented lung inflammation. NF-kappa beta, NF-kappa B is the regulator of the immune response. Ionizing radiation is known to activate NF-kappa B pathway, which is responsible for transcription of the various inflammatory cytokines like IL-6, IL-1 beta, TNF-alpha, etc. Elevation of these inflammatory cytokines following radiation causes inflammatory changes in the lungs. But Q3R significantly inhibited the expression of NF-kappa B and the other inflammatory molecules, and hence it prevented lung inflammation. Another very important cytokine is the TGF beta, which play important role in the fibrosis. TGF beta, it is responsible for differentiation of the fibroblast to the myofibroblast. Myofibroblasts express alpha smooth muscle actin protein and are responsible for remodeling of the extracellular matrix and collagen deposition, which contributed to fibrosis. Q3R significantly inhibited the expression of the TGF beta 1 and reduced the collagen production and hence minimize fibrosis in the lung tissue. So by this study, we concluded that Q3R provided radioprotection to the lungs by scavenging the free radicals, minimizing radiation-induced cell death, by preventing perivascular infiltration and prolonged inflammatory cascade, and regulating the NF-kappa B TGF beta signaling. And this molecule can be proved as a potential therapeutic agent for alleviating radiation-induced lung injuries. I would like to acknowledge our director in MAS and the organizing team of ICRB and also my colleagues who supported me for this work. Thank you so much.
Thank you, Savita. We are already running late the session. I hope to see you in Bikaner in the future in the next conference as soon as the COVID situation get normal.
Sure.
Now, thank you for nice and informative talk. And convey my regards to Honorable Mr. Sir, the director. He also given his kind message, best message to organize the ICR in Bikaner. Thank you so much.
Can I ask a small question?
Yeah, one question you can ask Dr. Kalia, sir, as a chairperson, Dr. Kalia.
Yeah, can I ask a small question?
Yes, sir.
See, vitamin E and there are some others, even vitamin D. They are known to protect from lung fibrosis and so many other ways. And they are even have been tried, vitamin E particularly as an adjuvant in cancer therapy.
Yes, sir.
Which way you think your compound compares with them? Have you done any comparative study or is there any study available in the literature? Because whenever we talk of a potential new compound.
Sir, I have not done the comparative study, but we are planning in future.
Okay.
This compound is also having many of the pharmacological properties, like it is anti-inflammatory, antioxidant, and it is also regulating the inflammatory pathway also.
Yeah, essentially similar to vitamin E, retinoids, and all those kind of things, those kind of effects. So what I meant was that when you are introducing a new compound in research, some comparative study validates and comparative data also comes.
Okay.
Yeah, I do have some personal experience with these things, though the data did not get published because I did not get to do that much of work. But anyway, I mean, that apart, I mean, the work is there, it is yet to be published in some respect. Please go on because the conference should go on rather than these individualized discussions. Dr. Prohit, please go on.
Thank you, sir.
Thank you, Dr. Kalia, sir. Next speaker, Anu Prakash from Inmas, New Delhi. Anu is here. Anu Prakash
Yes, sir.
from INMAS, New Delhi.
Yes, sir, I'm here.
She would speak on development and evaluation of di-allyl sulfide formulation. Anu Prakash, we already sent you link on your Gmail. I think she is not here.
Sir, I'm here.
Okay, Anu is okay. Please go ahead. Kindly conclude the talk within 8 minutes.
Okay, thank you so much, sir. Sir, I'm unable to see.
Yeah, we can see your slides. Anu, we can see your slide. Please go ahead.
Okay. Thank you, sir. Good afternoon, everyone. My name is Anu Prakash, SRF, working in INMAS. DRDO. Today, I'm here to present the topic development and evaluation of di-allyl sulfide formulation. As we all know, how radiation can be lethal. Sorry, sir, but I'm unable to change my slides here.
Wait. What's in the Suresh Verma? He is looking after.
Madam, please unmute करो. वहां से unmute करो. उस PC से unmute करो. मुझे
Sir, it's changing there. The slide is.
Madam, please reshare the PPTs and share the full screen instead of a particular window.
Okay, sir.
And it will be more better if you will on your camera.
Okay, sir.
Yes, please check whether the slides are. Yes, it's perfect now. Please.
Okay, I'm so sorry.
It's perfect. Please. Okay.
We all know that how the radiation can be lethal. The radiation dose received or observed determines the extent of radiation damage to tissue and for the organs. It causes the DNA double strand breaks and generate ROS, which can cause DNA damage such as a basic sites and single strand breaks. Cell death and the mitotic cycle failure occurs when all of these alterations occur at the same time. JAK inhibitors are a new class of radiation protectors and mitigators that can prevent the damage, even after the radiation has been delivered. In eukaryotic cells, DNA damage repair occur in the context of chromatin, and the DNA damage response affects specific aspects of chromatin structure. Histone variation, post-translation histone modification, and chromatin binding proteins all work together to drive DNA template-directed process, including gene transcription, DNA replication, and DNA damage repairs. It has been already shown that epigenetic mechanism modified DNA damage and repair pathways. Radiation countermeasures agents are intended to prevent, mitigate, or treat normal tissue damage caused by ionizing radiation exposure. There are two types of radiation countermeasures. One is radioprotectors, which are given before irradiation, and the radio mitigators, which is used to reduce toxicity even after the radiation has been given. As JAK inhibitors activity results in increased acetylation of histone protein and epigenetic alteration that result in relaxing of chromatin, leading to the transcription activation. Relaxed chromatin may give access to the repair protein to mitigate the effects of the irradiation. Presently, our group are studying two JAK inhibitors. DAS, di-allyl sulfide, is one of them. We are in a process of developing the potent radio mitigator and the formulation. Diallyl sulfide DAS, an organosulfur component of a garlic, is known to have a various therapeutic benefits and had recently been found to have a radio-mitigating qualities. GS also has an anti-mutagenic, antibacterial, chemopreventive, and hepatorenal-protective activities. In several studies, it has been shown that the DAS promote histone acetylation by inhibiting histone deacetylase enzymes, and it has been already established that intraperitoneal administration of DAS after 2 hours with the 9 gray of whole body irradiation had shown the 30% of the survival rate. So the hydrophobic nature and the stability of a DAS make it difficult to produce a suitable DAS formulation, administration method, and the ability to reach the target site of the action. To tackle the problem of solubility and stability, we chose to develop the various types of emulsions. Emulsion, microemulsion, and the solid lipid nanoparticles are the most intriguing carrier for oral drug administration because of their outstanding biocompatibility, good drug loading, and the long-term stability. Here is the preparation of my DAS SLNP formulation. Here we took the choice of our lipid with the lecithin and dissolved into the chloroform. After this, we took the aqueous phase. In aqueous phase, we have taken the different surfactant with the different concentration and added our lipid phase in aqueous phase with dropwise, or after that we have homogenized. We got oil in water course emulsion, and this water in course emulsion was further sonicated to get the DAS nano emulsion. Organic solvent evaporation was done by stirring, and the result formulation we got is the DAS solid lipid nanoparticles. Next was the preparation of the oil in water microemulsion. 100 microliter was drug is taken in canola oil, which is mixed with the 100 microliter in surfactant. Vertex was done for 5 minutes. During vertex, lipid phase was added to dropwise in aqueous phase. It was sonicated for 20 minutes, and then PDI size and zeta potential was analyzed. Here are the results and the description. In F1 to F4, if you can see that the variables, different variables are taken, but in F1 to F4, lipid taken was olive oil, surfactant was 20, and the sonication was 10 minutes for F1 to F2, whereas the sonication time is 5 minutes for F3 to F4. Surfactant, here the surfactant concentration was 1% and 0.5%. In F1, size was 160.6 nanometers, viscosity index was 0.542, and zeta potential is minus 50.9 millivolts. In F2, size was 151.7 nanometers, polydispersity index is 0.460, and zeta potential minus 51.3. Whereas in F3, 457.4 was the size, which is actually very high, and it might be because of the sonication time, which was reduced to 5 minutes. And the polydispersity index was 0.187, and zeta potential was minus 47.8 millivolt. In F4 formulation, surfactant was 0.5%, sonication was 5%, and the size we obtained was 335.2 nanometers, polydispersity was 0.336, and zeta potential was minus 50.9. In formulation F5 to F8, liquid taken was olive oil. Surfactant was again 20 with a different concentration from 1% to 0.5%. Sonication time was reduced to 1.25%. 1.25 minutes. Size we got was actually pretty high in the formulation from F5 to F8. The size we got is 923.4 nanometers in F5, 968.7, 1034, and 359.1 nanometer in F6, F7, F8 respectively. Whereas the polydispersity was 0.198 for F6 and zeta potential 0.0269. In F7, polydispersity index was 0.313 and zeta potential was minus 36.6. And in F8, the polydispersity index was 0.067 and zeta potential was minus 39.0. If we can see in F1 to F8 formulation, zeta potential was out of range, which is actually ideally is between minus 30 millivolt to plus 30 millivolt. Size was also very high in F5, 6, 7, and 8. But in F2 size was 151.7, but again, zeta potential was a problem. To overcome all these, we have developed another formulation F9 to F10, where the lipid we took was glycerol monostearate. Surfactant was 280, and here the homogenization was done at 11,000 RPM for 5 minutes and sonication for 20 minutes. In F10, the homogenization was done for 10,000 RPM for 5 minutes, where the sonication was done for 10 minutes. The size we got 46.63 in F9 and 105.2 in F10. Polydispersity index 0.395 in F9 and 0.026 in F10, and zeta potential was minus 64.1 in F9 and in F10 minus 12 millivolts. Here, by homogenizing at a very high speed and sonication for 20 and 10 minutes, we got the size within the range. So we can further, in F9, as we can see that the zeta potential is quite high. It is minus 64.1. So we can continue with the F10 formulation for our further studies. Next in the formulation, which is oil and water microversion, it is from F11 to F16. Here the procedure is the same. The only difference is different kind of surfactant we have taken here. Queen 80, Triton X100, Collagen 188, Queen 20, Tech 400, and Eclecticin. The result we got, the size were actually very good except for one, F15, where the surfactant used was Tech 400. The rest are within the limits. For F1, size was 11.99, F12, 51.33, F13, 159 nanometers, for F12, 106, for F15, 308, and for F16, 15 nanometers. Here the polydispersity index were for F11 0.339 and zeta potential was minus 0.831, for F12 0.487 and zeta potential was minus 0.621. For F13 the polydispersity index was 0.467 and the zeta potential was minus 6.1. For F14 polydispersity index is 4.38 and zeta potential is minus 2.6. Next is 0.314 and minus 20.5 is the polydispersity and the potential respectively for formulation 15 and 0.066 and minus 7.4 is were the polydispersity and zeta potential for F16. But here in this from formulation from 11 to 16, we saw the phase separation, which is not good in F12, F13, and F14, where Triton X100, Collagen 188, and Twin 20 was used as a surfactant. So this was these three formulation was eliminated for further study, whether and the F15 where the surfactant was Tech 400, the size was 308, which is out of range. So we are taking F11 and F16 for the further studies.
Anu, kindly conclude here. Thank you. Conclude.
So the conclusion of my study is the study's key challenges were in the lipophilic nature of gas, poor stability, and the low viability. Issue could be solved by developing formulation that increase gas viability and stability. Numerous formulation was made by different methods, surfactants and lipids. Further studies will be done with the selective formulation. Here are the references. Thank you.
Thank you, Anu Prakash from INMAS, New Delhi. Professor Kalia, would you like to make some comment on her talk?
Yes. Yes, I was muted. I had to unmute. Yeah. The work is very good. There is nothing to say except for one suggestion, it may be overbearing, but to a youngster, I can make such a suggestion. Her guide, we had met him in Bangalore also. The introductory slide, I was trying to go through, there was one slide which had a lot of text. The art can be perfected to keep the same information, but with very less text. That will be an evolutionary.
Dr. Kalia, excuse me, the whole face is not coming. Kindly keep your camera some distance away from your face. You can see only half of face. Keep the camera some distance away from your face so that we can see your whole face. Yeah, please continue. Please continue. Yeah. Please continue, Dr. Kalia. Please continue.
Yeah, what I meant was that the amount of text what was written in that introductory slide, it can be condensed with the same information content. That is the art of presentation I'm talking of. It is an overbearing suggestion, but it is from me to a youngster.
Thank you so much for the suggestion. I'll definitely incorporate in my next presentation.
Just work on that, because art of presentation is as much required for conferences and publications as the quality of work which you are doing.
Okay, sir. Thank you so much for the suggestion.
Thank you, Dr. Kalia. Now we shall move to the next speaker. I would like to introduce Dr. Arvind Sharma, a senior faculty member. He is professor of physics in Government Noble Bikaner. He is well known for his principles, his manual principle, and devoted faculty of our college. Dr. Arvind Sharma would speak on a specific absorption rate of mobile radiation and its reduction methods to protect the human body. Dr. Arvind Sharma, sir, may I humbly request you to finish talk within 8 minutes. Thank you so much. Mr. Prajesh Kumar Vaishnav here? Mr. Prajesh Kumar Vaishnav?
Yeah, sir, I'm here. I'm listening, sir.
Okay, you're joining online. Yeah. Okay.
Yeah, sir.
So please keep your talk ready just after this permission. Then
Yeah,
last
sir.
talk. Last talk. Thank you, Prajesh.
Okay, sir.
Thanks, Dr. Purohit. It's my pleasure that ICRB organizers gives me this fruitful opportunity to interact with scientists and scholars. Actually, my area of work is different nonlinear optics and photonics. In photonics, we are trying to make biosensors theoretically that can detect some diseases or other things. Today, I am going to talk on a topic which is not my area, but it is correlated with your conference theme. And my emphasis is like a physicist. Already Professor Shukla gives a talk on mobile radiation. My topic of this conference is specific absorption rate of mobile radiation and its reduction methods to protect human body. Basically, what are the parameters and where we can look, and what is the safety purpose for mobile radiation. And I took one parameter, specific absorption rate of mobile radiation, and how we reduct, or what are the reduction methods that are possible. Next. Initially, abstract of my paper is shown here. What are the physical explanation of SAR, and how you can detect, and what are the reduction methods, and what are the health side effects, and what are the protection methods. Next. Basically, SAR depends upon manufacturer and especially on antenna design. And antenna design depends upon materials used for antenna design. Next. Cell phones uses RF waves, and RF waves are waves between FM radio waves and microwaves. Next. Mobile phones are low-powered radio frequency sources operated between 450 to 2700 megahertz. There are government guidelines also for mobile SAR exposure. Specific absorption rate. Specific absorption rate is actually rate of radio frequency energy absorption per unit mass. And in different countries, as many things already told by Professor Shukla, in different countries, in European 2 watt per kilogram, in USA and India 1.6 watt per kilogram. Specifically SAR for different parts, head, body and eye. And in your mobile, head and body is given in your mobile. The unit of SAR is watt per kilogram or milliwatt per kilogram. It may be averaging your 1 gram or 10 grams per tissue of mass. The value of SAR can be observed by manufacturer, mobile universal code, hash, star hash 07 hash, or Federal Communication Commission. This is a table for different countries. In India, it is 1.6 watt per kilogram. Now, come to the point, specific heat of specific absorption rate. It depends upon few parameters, and its mathematical relation is integral sigma r ER modulus square upon rho r volume integral. And the calculation here is done over the specific volume, and if we see the physical parameters here, electrical conductivity. Number 2, induced electric field. What is the induced electric field? Field developed at a particular location inside biological tissue layer due to external incident RMS electric field strength. Third one is mass density of the tissue. Another relation where we can look is like C delta T upon T. Actually, delta T and T, this is temperature changes with time. C is the specific heat of tissue. Delta T is exposure, difference of temperature, and rate of time, that is exposure time. So if there is more exposure time, then there is difference in temperature of tissue also, and it can harm the body. If we see the parameters which we can look for or we can change, permittivity, loss tangent of biological tissue layers, shape of biological object, strength, polarization and direction of arrival incident wave. The strength, polarization and direction of arrival incident wave, it can also change the SAR value, tissue material density. These are the physical parameters or parameters by using we can change the SAR value according our initially I am giving a few methods that can be understood by anyone. That means anyone can understand. After that, some scientific methods are given. Method 1, if we use earphone or headphone that are useful to reduce the SAR value. Speaker phones keep calls as short. Special headphones. Special headphones are headphones using shielding materials. If signal is weak, then that is also increases the harmful radiations. EMF blockers. EMF blocking pouches are particularly helpful in decreasing exposure to other body. You should look up your specifications of your mobile according to your country. Now, few scientific and theoretical methods by using SAR can be reduced. Number 1, RF shielding. If RF shielding adding to mobile and it is placed in front of the phone by using ferrimagnetic materials. By using ferrimagnetic materials, because ferrite materials have low conductivity, which results in lower induced currents. And RF shielding is also used in 4 different, we can emphasis on 4 things. What is the location, what is its size, what is its shape, and what is its thickness. Use of highly directive antennas. Directive antennas helps to reduce radiation towards the human body, but it causes reduction in signal reception also. So it can be used according to its value of SAR. Adding metal strip. If a metal strip is added backside of the antenna of a mobile, if a metal strip is added on the backside of the antenna of a mobile, then it is also useful because it modifies the directional pattern of the antenna in the elevation plane to a pattern suitable for mobile. That means miniaturization of antenna is also reduce the SAR value. Number 4, compensation method. Compensation method is a method where auxiliary antenna is added between the transmitting main antenna and the user's head. Compensation method for creation of a weak field area near a transmitting antenna provides for reducing irradiation of mobile phone user's head without sacrificing or without changing the far field pattern. In this method, SAR is reduced efficiently. Initially, X-rays or radiation is harmful or not. An experiment is done by Nikola Tesla, and he put his own finger and it burns. And after that, Muller gets Nobel Prize for such kind of radiation exposures study. Electromagnetic radiation, that means here we are talking about mobile radiation is harmful for human body. That is already given by Professor Shukla. What is the effect? Where higher stress, fatigue, poor sleep quality, headache, weakened immunity, fertility issues, short-term memories. There are many kinds of losses. Cancers in tumor. There is also skin problems from mobile radiation exposure also. there are many kinds of studies are there. What are the main solutions according to physics? What can be done? I come to the three last points. We can use EnviroChip. EnviroChip is a kind of fix or forget solution fixed on a personal devices, including mobile phone, laptop, or tablets. And it makes the radiation non-bioeffective for humans. Number two, EnviroGlobe. EnviroGlobe nullifies radiation from internal and as well as external sources for mobile towers, routers, boosters. Similarly, EnviroGlobe only for mobile cover with radiation protection technology. So, in this paper, the physical explanation of SAR, what are the methods for calculation of SAR value, and what are the reduction methods, physical reduction methods, and what are the health side effects, and what are the solutions to reduce the SAR is given here. As I say, this is not my area, and I just prepared this paper for this conference. Thanks, Dr. Purohit, for giving me an opportunity. Thanks.
Thank you, Dr. Anil Sarma. Have you done some study on the mobile phone radiation or you say review article like?
No. This is my first paper.
Okay. Have you observed the SAR? How did you observe the SAR from different mobile phone radiation? You have mentioned the SAR. You have mentioned the devices.
No, I am explaining the physical explanation behind it and what are the physical technology which we can improve the SAR for different mobiles.
Yeah.
And we can emphasize on the antenna designing and what different kinds of materials we can use and how we can improve the SAR values. Physical explanation is there.
Being a secretary of Indian Society for Radiation Biology, this is an interesting conference. I advise you in future, you can use different mobiles. Yeah, you can have the how we calculate the SR value. What are the devices? There should be some scientific data also, so that your paper can be published in the interesting conference. Thank you very much.
Dr. Purohit, can I give some suggestion? Hello, Dr. Purohit.
Yeah.
Dr. Purohit. Hello. Hello.
If time is more, SAR value is less. Dystrophy is more, SAR value is more, one can understand. And basically, microwaves have the heating effect. So one can understand the more use of the mobile will produce more heating, will produce more SAR value. The factor, I don't know what this methodology which is adopted to define the SAR value. But my simple logic as a layman, I am saying, I have no experimental background over this. And I wonder whether if P is in denominator, so how will you explain this? मुझे लगता नहीं है कि टी डिनोमिनेटर में इस तरह की कैलकुलेशन होना चाहिए या जो हम SAR हम समझ रहे हैं if SAR is more dangerous or something else.
The time we are thinking about that is different. Here we are using C dt upon d small t. C is the specific heat of tissue and temperature rise with time. That is change in temperature with time that can affect the SAR value.
You mean to say?
Yeah.
Time for which the mobile is used.
No. Exposure time, that means it depends upon also specific heat of tissue also.
No, that's true.
Yeah. That is not like that. It is inversely proportional to time.
also important.
Yeah.
The wavelength less will be the energy of the photon. Hence, in small interval of time, there can be less energy absorption. And if the frequency of the incident then is large, but in the case of mobile radiation, there is a fixed value of, there is a range of wavelength which is used by all the companies. This is the topic of study here, that which range they are using and for how much time the exposure of the radiation becomes important.
That's the take care of all type of absorptions, which basically depends on what the gentleman is saying, because everything is related to the absorption. If absorption by a particular cell is good, naturally its effect will be good. And if absorption is less, its effect will be less. So, whether the term C, which you have said the specific meat of that particular issue, sorry. So, I wonder how the absorption is related to that heat. Because things are related with the absorption. One thing is very clear. If absorption is low, effect will be low. And absorption in terms is related with the heating. So that's why the term rise in temperature is there. So I think this empirical formula or semi-empirical formula or whatever the source may be, either we are unable to understand it or some correction.
This formula is commonly used in literature, and I think the explanation is behind that, like not time exposure. Okay, thanks.
Thank you, Dr. Rohit. Hello. Now the Dr. Purohit. Last speaker, Dr. Purohit. Mr. Prakash, you would you like to present talk today or we can substitute tomorrow? Sorry, no. Mr. Pradesh.
Yeah, I'm listening, sir.
Yes.
Dr. Yeah, I'm listening, sir.
Dr.
I'm listening, sir.
Actually, we have young scientists award session. All the young scientists they were assembled here. So please talk within 5 minutes. Can you finish?
Yeah, sir.
Sorry, Pradesh.
Myself, Ritesh Kumar Vaishnav. First of all, I'd like to thank Dr. R.K. Purohit, sir, and ICBR team for inviting me here for presenting my research work, which entitled Green Synthesis, Physicochemical Properties, Spectral Characterization, and Antibacterial Studies of Transition Metal Complexes of an amide moiety containing bioactive ligand. My plan of research is related to synthesize the ligand, which name is 2-hydroxynicotinamide, and also metal complexes related to this ligand, which name manganese metal, cobalt, nickel, and copper composite. I am using green method for synthesis these metal complexes and ligand with microwave process. Antibacterial studies also taken in part in my research work. With their metal complexes, I use 3 types of bacteria and study about their antibacterials. Why are we use 2-hydroxynicotinamide? Because the reason behind of that, this free ligand, nicotinamide, has a crucial role in glycolysis, fatty acid synthesis, respiration, and also has a protein and RNA synthesis. It is also essential part in vitamin B complex and energy. It is used in treatment of pellagra and schizophrenia, type 1 diabetes. A number of metal complexes of nicotinamide are found to have anti-tumoral, antiviral, and antituberculous activities. My objective behind my research work is designed to microwave assist synthesis, find out the biochemical utilities, also understand the coordination behavior between metal and their complexes and bonding between them. The biochemical investigation on these complexes will provide screening towards the development of drugs. These are the two methods by which we synthesize our metal complexes and ligand. First is a conventional method. In conventional method, we use 2-hydroxynicotinic acid. 2-hydroxynicotinic acid is reacted with thionyl chloride and methylene chloride, and after it reacted with ammonium hydroxide and it produces our ligand 2-hydroxynicotinamide. In microwave radiation, we use also 2-hydroxynicotinamide acid and reaction with ammonium hydroxide and ammonium chloride in microwave radiation for 3.5 minutes. Then we give 2-hydroxynicotinamide ligand. You see also the picture, both conventional method as well as in microwave radiation. The synthesis of metal complexes by conventional method is we use divalent metal chloride. It's reacted with into alcoholic solution of 2-hydroxynicotinamide, and then we constant stirring for 3 and 4 hours at room temperature, and then filtrate it. The filtrate was washed out at with 50% alcoholic mixture, and then dried in vacuum and recrystallize it. This is the picture you see about the conventional method by which we produce metal and their complexes. These are the apparatus we use for in conventional method. For synthesizing metal and their complexes by microwave method, we use microwave reactor. In microwave reactor, we put out a solution at 600 volt, and then different time interval with respect to occasionally or defined spec or PLC data. The mixture was cooled out, and then it chilled ice chill method to pour into ice chill method and dried in a vacuum. The solid precipitate obtained in both the method was separated and then crystallized and then recrystallized in alcohol. The whole microwave method process is done in our green chemistry lab. Its name is Green Method Biochemical Reactor at GCRC Green Chemistry Research Center at Government Women's College, Cutaneous. That is the physicochemical data of the ligand and their complexes. First of all, we show color of ligand and their metal complexes, then melting point, then reaction period, then percentage of yield, and method analysis. In this table, we can conclusively the reaction period in microwave method is less than compared to conventional method, and also the percentage of yield is also more than compared to conventional method. So that is the important part, because that's why we prefer the microwave method is very useful compared to conventional method. That is the vibrational spectra assignment of ligand and their metal complexes. We see CO stretching band in ligand and their metal complexes are going to decreasing in order, and also we see there the VOH bond is not present in ligand. We later on discuss about why the VOH bond is not present in ligand, and then next the metal moment of this spectrum are there.
Just kindly conclude. So, am I audible? Kindly conclude as it is possible.
Can't hear properly, sir.
Please go ahead.
These are complexes, RF values, new effective, electronic spectral bands, and tentative assignments. By the all, yes, sir.
Bridges, can't come to the conclusion, please.
Can't
skip all these things and come to the conclusion, please.
Yes, sir. Yes, sir. Yes, definitely. Just a few minutes. The all metal complexes, manganese, copper, nickel, and have an octahedral structure, but the copper complexes have distorted octahedral structure. The VOH stretching bond is not present in ligand, and also inactive of irradiant structure confirm that the ligand undergo keto-tautomerism, and possible it because of keto-tautomerism is more stable compared to enol totalism in the solid state. That is the tentative structure of complexes by which the complex in which metal ligands are attached with the metals. These are there are some graphs in which we show easily ligand compared to the manganese complexes. The biological investigation of ligand and their metal are using in nutrition agar medium. In this medium, we also study about the 3 types of bacteria: Escherichia coli, S. aureus, and Bacillus. The study indicates that the bioactive ligands and the complexes possess at least one type of biological activity up to substandard level, and active bacterial activity of complexes in most of these have been found greater than. This is the picture by which we show antibacterial activity showing zone of irritation, and that is the result against Escherichia coli, against S. aureus, against Bacillus subtilis. These are against Bacillus. Nickel complexes show more activity compared to copper complexes. The copper complexes show manganese more compared to manganese complexes, and manganese complexes compared to more cobalt complexes. That is the bar diagram related to the zone inhibition and the ligand and metal complexes, in which we saw there are 2 bar not present. One is the cobalt complexes, and the second is the nickel complexes. Escherichia coli does not show any zone of inhibition in cobalt complexes, whereas Bacillus is not show a zone of inhibition in nickel complexes. That is my conclusion with our research work, that the complexes manganese, cobalt, and nickel complexes have a octahedral geometry, whereas the copper complexes have a distorted octahedral geometries. All the prepared bioactive ligand or complexes have effective antibacterial activity against 3 types of bacteria. And microwave assembly is more useful and more beneficially synthesis for any type of metal complex, because it produces more yield and it takes up less time compared to the conventional methods. My future work is preparation to single crystal and X-ray crystallography, antibacterial activity against fungi and others, bonding and their docking studies. All instruments which is used in our research work on microwave synthesis was carried out GMDSCR and also UV spectro, Bookman optical model alpha, and Beckman anti-melting point apparatus. All apparatus are present at Clean Chemistry Research Center, Department of Chemistry of Government Rural College, Bikaner, Rajasthan, which is upgraded with 3 times A grade by NAC. Thanks to my GCR team, and a special thanks to Dr. S.K. Verma sir and Dr. N. Pocher sir. Thank you.
Thank you. Thank you, Brajesh, for very nice presentation in the given time. Thank you very much. Only one question may be asked from the audience.
Thank you. Oh.
If no question, thank you so much. I may request Dr. Aruna Chakrathi, our secretary, to continue the session further, because we have done post session for 10 minutes. Then we'll go for the scientist award. Dr. Aruna.
Very nice session. Thank you, sir. May I invite Dr. Smita Jain, Dr. Athyaman, Dr. R.K. Purohit, and Dr. Manisha Agrawal. Sorry. For token of respect, may I invite Dr. Smita Jain.
ये जो सेशन चेयर किया जिन्होंने कैपिटल चेयर कैपिटल बहुत अच्छा बढ़ गया और पैकेज जो एक मिला अंदर क्या एक रोज को आ रहा है For time being. Yeah. She also chairs again? Yeah. Sir, chairs. Yesterday also. He's actually possibly see attending all the classes.
One more Dr. Purohit.
We start with the exposure. I will come out to taking the supposed to start thank you.